table. One family who didn't complete it because the husband migrated. But that doesn't mean if woman wants to kind of withdraw from the trial because of the migration plan and all, everything, she can do it. For the sustainability component, I think we are doing this with work, right? And we are not doing as a researcher, as a research organization independently. We wanted to translate the evidence, the intervention into practice. So that was one of our key discussion points in terms of how to make these interventions sustainable if it works, right? First, we need to know whether it works or not. So we worked with our partner like Warwick, and even in the next phase when we are doing expanding this, now we know it's acceptable at least, right? So we are working with different other partners who are working in the domestic violence area and trying to get the participants from their network in our study participation.
Thank you, Dr. Savitri, for your wonderful feedback. So I'd like to invite our next speaker. The next speaker is Lama Engjen Sherpa, and we call us MC Truk. They are on the behalf of UNFPA, I guess. So they will be presenting on the topic entitled Achieving the Global Target for SDG 3.1 in Nepal, maternal mortality of less than 70 by 2030. Dr. Lamo is a medical doctor with a PhD in epidemiology. She has worked for almost 13 years in M&E and research, nationally and internationally. She has also served as a commissioner for indigenous and tribal people health for the Lancet, investigating maternal health from indigenous perspective. So they both represent UNFPA. Thank you.
We just need the slides, please. Thank you. But it's not showing that. Yeah. Okay. Yeah, good afternoon, everyone. My name is Nick McTurk. I'm the Census Coordinator with UNFPA. And it's a pleasure to be here this afternoon with my colleague, Dr. Lamo, to talk about how Nepal might achieve its national target of 70 maternal deaths per 100,000 live births by 2030, which is also the global SDG target for maternal mortality. Today I would like to just discuss two methodologies. The first one is the UN methodology for estimating maternal mortality. It uses national data, modelling, and other predictive variables which are known to be associated with maternal mortality to create time series which are internationally comparable. And the most recent time series was released recently for the period 2000 until 2020. And the second methodology was actually a groundbreaking study that UNFPA was proud to support, undertaken by the Ministry of Health and Population and the National Statistics Office, based on the 2021 census, which provided a national point estimate for 2021, as well as sub-national data, which was actually a major achievement for Nepal within the region. And also the study provided a great deal of information about the causes of death which are associated with maternal mortality. Firstly, looking at the UN estimates, Nepal is ranked in 2020 51st out of 185 countries globally. Now, Nepal has achieved a lot. Since 2000, the MMR has come down from 504 to 174, which is commendable. But during that period, Nepal has always remained second in the region, behind Afghanistan, among countries in South Asia. So there's still a lot to be achieved. Now, we did some initial analysis to assess, based on the UN data, what it would take for Nepal to actually achieve 70 maternal deaths maternal mortality ratio rather, by 2030. And we estimated that it would be required to reduce the number of deaths per year 10% every single year between now and 2030. Now, this would be a major, major challenge, and I think it's important to note that we would need to really start immediately to work on this effort, and we look forward to working closely with the government, ourselves at UNFPA, to achieve this target. So, turning to the study undertaken by the Government of Nepal with UNFPA's proud support, the ratio that was estimated is lower at 151 deaths per 100,000 live births. Now, this is also within the 80% uncertainty interval range for the UN estimates, which is very encouraging. We also note that given the data from the census provided much more detail, it was able to provide subnational estimates. And you can see from this map that there's quite large variations nationwide. There are also variations by age, which is not uncommon, with higher ratios for teenage girls and older women. So the study, or both studies I should say, offer very good start points for future work to reduce maternal mortality in Nepal to achieve the target of 70 by 2030. And I'd just like to say that with the release of the census results, we now have the opportunity to do more thematic analysis. And one of the areas that we can look at is maternal mortality by the background characteristics of the households of women who have passed away, and also the characteristics of the heads of households that they come from. Also, the population projections will allow us to do a lot more work around modelling how to reduce maternal mortality over the coming years. But one of the most critical things is actually we need to strengthen civil registration by improving birth and death registrations. A well-functioning civil registration is the gold standard for mortality measurement. And thirdly, I'd just like to make the final point before I hand over to Dr. Lamo, that strengthening geographical information systems is also very important so that we can look at vulnerability across the country at local level, especially around access of women to reproductive health services in their local community. So I'll pass over to Dr. Lamo now. Thank you very much.
Good afternoon, everyone. So now I'm moving on to maternal deaths by place of death. As we can see from the census, I'm using the census data, 26% of the deaths were due to delays in deciding to seek health services, emergency obstetric and neonatal care services, 17% due to delays in reaching health facilities, and 57% of the delays were in receiving health care. So it's possible that for these deaths in health facilities, it might not just be a variability in health system performance and health system quality, but also as a result of delay in seeking care and delay in reaching the health facility that might have contributed to a high facility-based fatality rate. The next slide is, we're looking at the causes of pregnancy, and this is also from the census. This result also shows that there's a very high proportion of deaths that have occurred due to obstetric complications. So what would be the way forward for Nepal? Especially for Nepal, it would be investing in 3 pillars to reduce maternal deaths and mortality. The first pillar is EMOC, which includes health workforce, supplies, equipments, referrals, transportation. The second one is skilled health personnel, which means more midwives, nurses, community outreach workers, empowering health personnel. And the third one is birth spacing. As a majority of deaths, as we have already seen in the previous slide, were directly related to obstetric complications, including hemorrhage, hypertensive disorder, infection during pregnancy, it is imperative to invest in EMOC and skilled health personnel, because the most common causes identified by the census in 2021 in receiving care were delay in identifying risks, delay in treatment and admission, administrative delays, inadequate communication, lack of essential equipment, availability of trained health workers, delay in blood arranging, and shortage of medicines. As a result, investment in the three pillars must occur concurrently, as we have seen in the previous slide, that 70% of maternal deaths will still continue to occur due to obstetric complications if there's lack of investment in EMOC and skilled health professionals. Obstetric complications cannot be averted only by preventive measures such as screening during antenatal care, because we don't know when the complications will occur. So management of these complications will require EMOC and skilled health personnel. The second one is social determinants of health. While we continue to engage in clinical side, we must also address the social determinants of health, which include poverty, literacy, education, exclusion, gender inequality, as the causes identified by the census are difficulties in arranging finances, unavailability of transportation, unable to get permission to go from home, are all the social and societal determinants of health, and these are systemic inequities. And finally, harmful practices is important because child marriage and early pregnancy, as well as late pregnancies, both which are in the extreme ends of reproductive years, are a risk factor for mother and the baby. Gender-based violence and mental health is equally important, as 6% of the deaths reported in the census were due to intentional self-harm. So this is one slide. This is also a study published in the Lancet to show how much maternal deaths can be averted, newborn deaths and stillbirths can be averted if we have educated and regulated midwife-delivered interventions. So we need to assess what is doable in our context. And our final statement is from the Executive Director of UNFPA, who said that major investment in maternal health is needed now more than ever to save lives and make childbirth. And this is very crucial in the context of Nepal, as we have already observed from the census data that the sex ratio is skewed with more male children. We already have met the SDG indicator for TFR with a fertility rate of 2. Now, if we do not invest in maternal health, particularly for women who want to become pregnant, who want to give birth, Nepal may face the problem with the burden of an aging population in the coming decades, which is why major investment in maternal health for women is needed now to reduce maternal deaths by 10% each year to achieve SDG target of 70. Thank you.
Thank you both presenters for excellent presentation. Now the floor is open for discussion. We may take one question only. Just one question from the floor, please. Edwin, yeah, very quick question, please.
A very quick question. Am I right in thinking that training midwives is more important than increase the number of hospital births?
We have a third presenter. So the third presenter is Dr. Biba Simkada. She will be presenting on her topic, Culture, Practice and Policy in Dementia Care in Nepal. Dr. Biba is a senior lecturer in adult nursing and deputy director of graduate education in University of Huddersfield, United Kingdom. Her research interest includes health and well-being of vulnerable population, dementia care, health inequalities, women's health, and capacity building of nurses and midwives. In fact, Dr. Biba is also my collaborator. We have been working since last 10 years in different research projects. Dr. Biba, please.
Good afternoon, everyone. Good afternoon, respected chairs. First of all, I would like to thank scientific committee, organizing committee for providing us opportunity to share our work. And this work we conducted with the Bournemouth University, Aging Nepal, and ourselves in University of Huddersfield. And as we know, dementia is a growing problem in worldwide, and it is a public health problem everywhere. And it is dementia is known as a term to several diseases that affect memory, thinking, and ability to perform daily activities. We know it is affecting most of the families because of the disease condition worldwide. And we know people are living longer, and more people are living with a dementia is growing. And currently 55 plus million people have dementia worldwide. And most of them, majority of them live in low and middle income countries. And therefore, it is very important how we manage this dementia and provide early intervention as well. And there is an increased dependency to the family and carer because of the dementia, because people are forgetting the things and they are not remembering. And people now we can see the nuclear families growing everywhere because of the migration and lack of awareness on dementia, disease as well, care provision, and there is around policy and stigma also causing the huge problem in dementia care. And similarly, dementia brings numerous challenges in Nepalese context. And Nepal, the dementia is very new terminology and it is neglected area of the disease in Nepal. And one of the things is because of a lot of people are migrating abroad, and it is increasing, changing family dynamics, also causing the huge problem to look after the family living with the dementia. And also it is creating the huge cost burden to the healthcare. And also we do have a lack of policies and resources within our healthcare system as well. And there is a need, therefore there is a need to understand how this dementia situation is affecting the people living in Nepal. And therefore, we wanted to explore what are the cultural practices and policy influences dementia care in Nepal, and we want to understand the perceptions towards dementia in Nepalese community, and also want to understand different policy and service provision available for the people living with dementia and their family. And to understand this dementia care and services and policy, we use a qualitative approach and conducted focus group discussion and in-depth interviews. And we conducted 4 focus group discussion, 3 with caregiver family members and 1 with other stakeholders. And also we conducted 4 in-depth interviews with 1 family caregiver and 3 health care professionals. And with the data we identified from this research study was conducted using the thematic analysis. And our study identified the 4 major themes, and one was the cultural practice in dementia care, and there are several sub-themes, but a couple of them are stigma towards dementia terminology as well. And we can see how different respondent has responded, how this disease is seen in the community. And people do not want to share, even they have a dementia or early sign of dementia, they don't want to talk if their father and mother has got dementia, because people think about, oh, this is their past, from the past behavior they are experiencing from their past or bad things. and they have said paap dhuri dakharaउँछ, similar type of things. And similarly, other things where people do not want to share their fathers and mothers' problem with the other to seek a help because of again, they have a fear with the community and societal barrier, social pressure as well. Because, our culture is keeping our parents with us, and this is our culture. But if you keep your parents away from yourself, you are seen as a bad person, bad family. That's why a lot of people are experiencing this kind of problem in Nepal. And we can see one of the very interesting example in the final quote I'd like to highlight. One of the dementia patient's son was sharing, he used to keep that light on in his father's rooms, although he already taken his father to the Vridhashram care home. That means free care home, and he used to tell father was still at home. But later on, after a few months' time, people found out his father was already in the care home, and because of he could not afford the care cost. That's why he had no choice. And similarly, other theme we identified was the impact of policy in dementia care. As you know, we have a very different health policies and different part, but older people's health are still neglected. And when we interview some of the health worker and policy maker, they were still drafting the policy around the dementia care for older people's health. And there are very few hospitals has a geriatric ward. It is recently been developing, and all of those geriatric wards, they don't have a dementia specialized facilities and care. And it is very difficult for people to care, or health professional to care the person living with a dementia. And similarly, in the service provision as well, it is mainly the service are around Kathmandu Valley, and one of the things is, the policy, they have the 1 lakh for Parkinson, something like that, and they don't have anything for the dementia, person living with a dementia, and they struggle to get the money from those.
2 minutes. 2 minutes.
Okay, thank you. And also, we also identified the education and training. There was a lack of training and education around the dementia care. And especially when we interview the nursing professionals and medical professionals, they highlighted they hardly had anything around the dementia care, how to look after these people, person living with a dementia. And finally, I will just highlight some conclusion. And stigma and stereotyping around dementia need addressing in Nepal. And Nepal needs better policies and guidelines and service provision for older people, and especially people living with a dementia and their carer and their families. And there is a need for inclusion of dementia Alzheimer education in undergraduate, postgraduate curriculum of the nurses, doctors, and allied health professionals in Nepal. Thank you for listening.
Thank you, Dr. Biba, for keeping time as well. So now the floor is open for discussion. We might take one question from the floor, please. If not, maybe I'll ask a question. Yeah.
Thank you for the wonderful presentation. I'm Milima Singh, working at NHSSP. I wanted to ask now, now this study is completed and you have the findings, what is the plan to translate this evidence into action for policy makers? What would you suggest? You have said better policies are needed and the curriculum needs to be revised. But if this university or other people in the community are given the role, would they be able to draft the content for the policy and for the course itself? Yeah, thank you.
Yeah, thank you. Very important question, I think. And we are already thinking about it, and we are already discussing with some of the university as well how to revise some of the curriculum. Coming from nursing background myself, I'm already involved in some of the curriculum design, and I am already talking to the colleagues in different university. But I think we still need to discuss with the medical MBBS course program as well. I think we need to raise the awareness first, and then we can move forward. I think first step would be the awareness raising. And then in terms of policy, I think we still need to raise awareness and reach to the government policy leaders and political leaders as well to raise this.
And just to complement what Dr. Biba has said, and regarding your issue, I think there needs some sort of intervention with regard to raising awareness for the health worker on stigma reduction. So we need to capacitate our health workers so that they will be able to handle the stigma, because this is what the research has shown. So we need to run some capacity building initiative for our health worker in order to capacitate for stigma reduction endeavor as well. Thank you.
Yeah, thank you, Dr. Sultan.
So now we have the final speaker, the invited speaker for this session. He is Dr. Krishna Aryal, and Dr. Krishna Aryal will be presenting in his topic entitled Ensuring a Fair and Efficient Path Towards Universal Health Coverage, Judicious Priority Setting of Health System Intervention. Dr. Krishna did his MPS from Institute of Medicine, Tribhuvan University, and his PhD in Public Health from Faculty of Medicine, University of Oslo, Norway. Dr. Aryal has a major area of focus on chronic disease epidemiology and translation of research into policy and practice, supporting evidence-informed policy decision. Currently, Dr. Aryal is affiliated as a senior researcher with University of Bergen, Norway. Dr. Aryal, please.
Thank you so much, Chair, for introducing me with this wonderful lines of introduction. Thank you, NSRC, for giving this opportunity to present here in front of you all, in front of this August gathering. I'll be talking about universal health coverage today and how do we aim or aspire at realizing it through fair processes of priority setting. That will be my talk. It looks like there is some technical glitch. It's not changing. Give me a minute, please. त्यहाँ चेन्ज भएन कि एकचोटि कसैले हेरिदिनुहुन्छ यो यसबाट गयो भन्नुहुन्छ कि भनेर हो मैले ओके अब भयो होला I think it's working now. Yeah, thank you so much. So I'll be talking in my today's talk based on these two reports. That's Making Fair Choices on the Path to Universal Health Coverage by WHO, and a book on global health priority setting beyond cost effectiveness. Do we have enough on cost effectiveness, or we need to move further beyond cost effectiveness to make intervention decisions at the policy level? And I'll base my presentation around this famous UHC cube from the World Health Report 2010, which is pretty familiar to many of us. I'll talk about a little bit about UHC and its dimensions, and then I'll touch upon the core of UHC, that's about prioritizing the services. And then I'll talk about expanding coverage and reducing out-of-pocket payment. And those are the two other dimensions of the UHC cube. And then I'll talk a little bit about how do we approach priority setting relating to the context of Nepal. As you all know, universal health coverage, as it is defined, it says that all people receiving quality health services that meet their needs without being exposed to financial hardship in paying for the services. That is the crux there. And given resource constants, like in countries like ours, this does not entail all possibly effective services, but we need to compromise with a comprehensive range of key services that is well aligned with other social goals. And this has become more important in our context because we know now that the development assistance for health has plateaued, and we also know that there is insufficient growth rate in domestic funding and health, so that can minimize the gap. So we have less funding domestically, but also development assistance for health is also plateaued. And then in this context, what a country needs to do, or what a country needs to aim in the path to UHC. We want to achieve maximum equitable health outcomes, that is our goal, and we want to reach to improved health and well-being, and then at the same time, we want to make sure that we reduce the unfair inequalities. So the path towards UHC, the approach is not that easy, because it involves redistribution and setting limits in certain areas. And we all know that no country can possibly fill the entire cube, and hard choices have to be made. While making choices, there are two aspects. One is about substantive fairness, which talks about what we need to include, what priority areas, what areas we need to focus, what interventions we need to focus on. And at the same time, while we are doing that, we also need to make sure that there is procedural fairness as well. The process towards determining what services are included, what population is covered, there has to be procedural fairness in terms of ensuring right intervention is chosen, right population is targeted, and we are doing the processes in a right way. Let me dissect the cube a little bit and then try to explain like what is each of these dimensions of the cube entail, and then like how can we take the reflection. The first one is about the health outcomes, the level and distribution of the outcomes, and we need to make sure that the decision makers need to decide which services they want to expand first. We need to decide on the services that we want to expand first. And then the second is about, once we decide what services are required or what we are focusing on, then we need to think of like including more people, expanding service coverage to more people, and then we need to make decision that whom to include first. That is another aspect of the cube. And the third one is about, while doing so, we need to reduce the out-of-pocket payments. Decision makers need to decide how to shift from such payment towards prepayment. And on top of this, there is an issue of cross-dimensional priority setting as well. Decision makers have to trade off progress in one dimension against the progress in others. Let me go further deep in those dimensions of the cube. While categorizing services into priority classes is the first one, we need to use the relevant criteria for categorizing services into priority classes, and then we need to expand the coverage of the high priority services, and then we need to work on cost sharing and then the fees. That means eliminating out-of-pocket payments and increasing mandatory progressive payment with prepayment with pooling of funds. And while doing so, we need to ensure that the disadvantaged groups are given the priority. In Nepal's policy and strategies, we have been hearing about this. We now are going to have a new health sector strategy in the country very soon. That's coming up. But the current health sector strategy, the strategy until 2020 and extended till July 2023, it had embraced the universal health coverage at the core of 4 strategic directions that it took. And then we can see in the strategy, in the status and roadmap of SDGs by Nepal National Planning Commission that UHC is again highlighted there. In terms of progress, where we have reached so far, the UHC service coverage index is 53, which is quite below than the global average. And achieving this UHC is not possible overnight, and we need some judicious priority setting for ensuring a fair and efficient path towards universal health coverage. What happens in our context? At macro level, policy decisions are guided by national plans and strategies, like the national policy, health sector strategy, 5-year plans. And then these are aligned with the global goals such as SDGs. And in the meso level, these are guided by the strategies and by evidence. Is it now time to take one step ahead towards a systematic approach of making policy and intervention decisions? If so, we need to start doing some priority setting exercise. That's what is the theme of my talk today. And then I'll try to go a little bit faster. This is just an example of why we need to prioritize. When we talk about universal health coverage, we are still yet to realize the universality, where we can see from these examples of like coverage indicators that several indicators we are far behind still. And then while choosing the priorities, we need to make sure that we follow certain criteria of cost effectiveness, and then we need to make sure that we have focus on the priority to the worst of and the financial risk protection. And then we come up with high priority, medium priority, and low priority services. The first dimension of the cube, which is very much important about population coverage, we need to expand coverage of the population to low income groups, focus on the disadvantaged group first, and then use targeted approaches where these are effective to ensure fair inclusion. And then about the reducing out-of-pocket payments, we now know that 57% is out of the total current health expenditure is borne by the household OOP, which seems to be a little bit reduced by the latest report, which is yet to be published, I believe. And then there are a lot of barriers to access to health services, which is caused by these out-of-pocket payments. And hence, we need to reduce that and then move towards the prepayment. And then potential approach towards doing that will be developing a set of criteria matching the local context. And we think that the ministry, it's high time for ministry to establish a transparent, legitimate process for priority setting, using a framework for efficient and priority setting, and institutionalize that within an appropriate unit. The process could be something like this. I don't want to go into each of these boxes, but we need some evidence on epidemiology, some evidence on intervention coverage, and then some evidence on cost effectiveness analysis, and then we can move from there. To make this task easier for policymakers, we have a tool called Fair Choices DCP Analytics tool, which is developed by the University of Oregon team with the University of Washington team using the DCP approach. And this tool can be used for priority setting exercises like this. The final key message is accelerating our progress towards universal health coverage is inevitable to maximize the population health outcomes equitably and with financial risk protection. And there is no alternative to priority setting using a systematic and evidence-informed approach to recommend a health benefit package to guide the health sector interventions. For that, we need to ensure rigorous mechanism ensuring a fair process and institutionalize it within the relevant unit for ensuring the exercise, and then align the package that comes out of these priority setting exercises with other health system instruments such as sector strategy and fiscal space analysis. Thank you so much.
Thank you, Dr. Krishna, for your wonderful presentation. The time is running out, so we don't have time for question answer. So maybe you can ask Dr. Krishna during the break if you have any issues. Thank you, Dr. Krishna. Now I'd like to hand over microphone to my chair, Dr. Bhojraji.
Thank you, Professor Susan. Good evening, everyone out here. Thank you, NHRC, to get opportunity to chair this session, a session with a population of health topic. The topic itself is very important since it's interdisciplinary approach to get positive health outcomes in our society, addressing mostly the social determinants of health. So we have already listened to the four eminent invited speakers, and the rule goes the same for the coming presenters. We have 5 presenters. We'll start with Dr. Om Kurmi. He will be talking on Nepal family cohort study in Lumbini cultural and Waling municipalities, opportunities and challenges. Dr. Kurmi, please proceed your presentation.
Good afternoon, everyone, and thank you for allowing me to present my work, which we are carrying out in the Lumbini and the Waling municipality. We all know once you are born, you will die, but dying before 70 shouldn't be the norm and shouldn't be acceptable as well. And why do we die early? So you might have heard about the David Becker's hypothesis, the fetal programming, where he says the intrauterine growth retardation, low birth weight, and premature birth are causally related with number of chronic disease. It's not only the prenatal factors. There are other factors, I mean, in the postnatal factors as well, and children exposure to environmental exposures, many other factors, they are associated with early morbidity and mortality for a number of health conditions. When you look at this figure there, and this is the number of major risk factor, death due to major risk factor in Nepal, and the air pollution is one of the most here, which is the fourth in globally, but for Nepal it is the number one. When you look at the second graph here, the good thing is that the indoor air pollution is coming down in the last 2 decades, and you can see the death due to indoor air pollution, but the worrying thing is the outdoor air pollution is increasing as well. And we are the number one country in the South Asia where the death due to air pollution is the highest. So what happens if everyone can reduce the air pollution to the global WHO guidelines? Each children born today will get 4.1 years of additional life. That's a huge there. The other factor we see a lot of symptoms, and the chronic disease, whether it is asthma, whether it's COPD or other. But when you look at the diagnosis, there is very little amount of data showing this. For example, for asthma, you have got only 1% of the children with asthma diagnosis. When you look at COPD, there are very few as well. And I think these are underdiagnosed conditions. We don't diagnose them early, and we diagnose them late, and there are, because of we diagnose late, there is a number of increased mortality as well. And you can see the air pollution here, mainly the respiratory conditions, the COPD, acute lower respiratory tract infections, cancer, and many other factors. The death due to them is much higher as well. We also did a study in close to Kathmandu and the periphery long back, and I think the condition remains same. What we found was the young adults, 16 to 25 years old, those who were exposed to household air pollution has reduced lung function. Once you have a reduced lung function, you are likely to develop number of conditions, non-chronic, chronic disease as well. So in this, we established the Nepal Family Court. It is ongoing. At the moment, we are collecting the baseline data in the Lumini municipality, as well as some of the partners are here. And the reason of doing this study are there is a number of gaps. We want to, as I mentioned, there are like 25, 30 major risk factors. We want to measure all those risk factors as well, including the air pollution as well. We need to have contemporary data from Nepal and longitudinal studies. My experience with many other universities who have done very long, 15, 20 years of data, I think it's time for us to start in Nepal as well. And in this study, what we do, we just triangulate the epidemiology of respiratory disease. We also measure directly the exposure assessment and also the biomarkers. So we are trying to combine the 3 components in this cohort study. So the major research hypothesis was that the majority of disease, including respiratory disease, is determined by risk that we accumulate through life, particularly in early years of life. So what was the the main research objectives was to to find out the major determinants of lung health. And once you determine those determinants, whether reducing those determinants, does the health condition improve or not? Many studies have shown from the high-income countries that it does work, and we want to find out from Nepal as well. So this is the cohort we are carrying out in Lumini municipality, as well as we have just started in the Walling municipality as well. And this is a prospective cohort intervention. I think this is one of the first family cohort in all the developing countries. I haven't seen, to my best of my knowledge, I haven't seen any data in any developing countries, the family cohort. And what we want to do is here measure follow the children every 2 years and the parents every 5 years as well. And this is 6 to 9 year old. We go house by house and collect the data. And there are a number of partners from here, US, and other countries. I'm not going into details. And the major outcomes, the primary exposure, we measure the exposures, number of lifestyle factors like dietary factor using food frequency questionnaires and many other aspects. The primary health outcomes are respiratory lung disease, whether lung function, asthma, acute lower respiratory tract infection, and the population is the parents as well as the children between 6 to 9 years old. We are measuring number of the factors over here, and some of them we also wanted to do like we haven't collected any virus data. We want to do the omics like genomics, the metabolomics, and the proteomics as well. So we haven't started, but we want to do that in next phase. You can see here there are a number of other outcomes which we are studying as well. So what we do here is use two methods. One is use the questionnaire. We collect the questionnaire in the tablet, in the red cap. There are a number of questions related to background, the lifestyle factors, smoking, dietary, physical activity, reproductive history, and many other health conditions as well. We also do some of the measurements like bioimpedance. I think this is the first one in Nepal, 4-limb Tanita measurements as well, blood pressure, spirometry, and exhaled carbon monoxide, and you can see so many other factors we are doing there. The second, this is the process how we collect. We start with the consent registration and the consent form, and then followed by the
You have 2 minutes more.
Questionnaires. We do some anthropometry measurements, you can see there, and followed by the physiological measurements and lung function assessment as well. And these are the how we collect the data there. So far, this is the baseline. We haven't got any result yet. We haven't analyzed. And this is the overall recruitment so far until April 10. So so far we have collected 6,170 participants data, 5,217 from Lumini, and around over 950 from Walling district. We also have measured the lung function. I think this is the largest lung function measurement post-bronchodilators in Nepal and many other countries as well. So this is I think it will be a good resource, and maybe in the next year we'll be able to share some of the finding to you as well. So these are some of the funding which we have, and also recently we got from the Nepal Health Research Council, the provincial grant, and thank to them as well. And I'm open to any questions. Thank you.
Thank you, Dr. Kurmi. We invite 1 or 2 questions, please. We can take 1 or 2 questions, please. If there is no question, we can proceed now with another presenter, Ansuraj Dahal, who will be talking on prostate cancer in male and breast cancer in female, make the largest cancer pool in the world and in the EU 28 and EPTA. Please, Dr. Ansuraj Dahal, please proceed.
प्रोस्टेट क्यान्सरको हो खै चाहिँ मैले त स्क्रिनमा देखेँ यो फर्मेट अर्कै भयो जस्तो छ
के भयो
अफ गर्दा तपाईँको यो फर्मेट पिडिएफ भयो क्या पिडिएफ फर्मेट भएर सर नखुलेको हो मैले दुईवटा स्लाइड सेन्ड गरेको थिएँ त दुईवटा स्लाइड सेन्ड गरेको थिएँ एउटा पिडिएफ छ एउटा त्यो पनि छ तर यहाँ डाउनलोड गरेर हिँड्छ पिडिएफ हो पिडिएफ चाहिँ देखाइरहेको छैन अनि त्यो अर्को पावर पोइन्ट पनि पठाएको थिएँ यो त्यो चाहिँ डाउनलोड गरेर हिँड्छ कि त्यो चाहिँ प्रब्लम भयो
Okay, due to the technical problem, we are proceeding with the next presenter, Bijaya Khatri. Bijaya Khatri, who will be presenting us on utilization of eye health services among adolescents starting in community schools of Bagmati province, Nepal. Please proceed with your topic. Bijaya Khatri.
थ्याङ्क यू चियर्स सबैलाई मेरो नमन छ आज म मेरो टोलीको तर्फबाट युटिलाइजेसन अफ आई हेल्थ सर्भिसेस एमङ एडोलेसेन्ट्स स्टडिङ इन कम्युनिटी स्कुल्स अफ बागमती प्रोभिन्स नेपालको प्रेजेन्टेसन गर्न गइरहेको छु नेपालमा चाहिँ यो आँखा स्वास्थ्य सेवा चाहिँ नि कि त एनजिओ रन सेन्टर्सहरूले दिनुहुन्छ कि त प्राइभेट हस्पिटल्सहरूले दिनुहुन्छ अथवा मेडिकल कलेजहरूले दिनुहुन्छ तर नेपाल सरकारको स्वामित्वमा भएको संस्थाहरूबाट चाहिँ नि विद्यालय आँखा स्वास्थ्यको सेवा दिइन्छ त्यसै कारणले पनि होला यो हाम्रोमा चाहिँ नि यो आई हेल्थ लिटरेसी र आई हेल्थ सर्भिस युटिलाइजेसन चाहिँ अलिकति न्यून छ र अचेल चाहिँ बालबालिकाहरूमा चाहिँ रिफ्र्याक्टिभ एरर चाहिँ नि अलिकति ठुलै मात्रामा समस्याको रूपमा देखिरहेको छ रिफ्र्याक्टिभ एरर भन्नाले हामी यसलाई दृष्टिदोष पनि भन्छौँ अथवा हामीले यो चस्मा लगाउनु पर्ने कारण जुन छ त्यो पनि रिफ्र्याक्टिभ एरर नै हो है अब यो रिफ्र्याक्टिभ एरर पनि एउटा पब्लिक हेल्थ प्रब्लमको रूपमा रहेको छ यसलाई पनि हामीले अर्ली डिटेक्सन रिफरल र ट्रिटमेन्ट गर्नुपर्ने हुन्छ र रिफ्र्याक्टिभ एररको कारणले गर्दाखेरि चाहिँ नि बच्चाहरूमा चाहिँ नि आफ्नो डेली एक्टिभिटिज होस् एजुकेसनमा होस् अथवा यसले चाहिँ लङ टर्ममा चाहिँ नि क्वालिटी अफ लाइफमा पनि असर गर्ने हुनाले यसलाई चाहिँ हामीले एउटा इस्युको रूपमा लिनुपर्ने हुन्छ र नेपालमा चाहिँ नि आँखामा समस्या देखिएका बालबालिकाहरू चाहिँ नि यो आँखा स्वास्थ्य केन्द्रमा नपुग्ने को चाहिँ स्टडी चाहिँ नि नदेखेको हुनाले हामीले यो स्टडी चाहिँ गरेका हौँ है यो स्टडीको अब्जेक्टिभ चाहिँ नि हामीले फ्याक्टर्स इन्फ्लुएन्सिङ युटिलाइजेसन र रिजन्स फर नन युटिलाइजेसन चाहिँ हाम्रो यो स्टडीको अब्जेक्टिभ रहेको छ यो चाहिँ हामीले एउटा मिक्स मेथड सिक्वेन्सियल एक्सप्लानेटरी स्टडी गरेका हौँ र यो चाहिँ एउटा प्रोजेक्टको भएको हुनाले हामीले यसमा 6वटा जिल्ला बागमती प्रोभिन्सको 6वटा जिल्ला लिएका थियौँ र 6वटा जिल्लाको सामुदायिक विद्यालयहरूमा चाहिँ हामीले 120वटा सामुदायिक विद्यालयहरूमा चाहिँ यो कार्यक्रम लागू गरेका थियौँ र यसमा चाहिँ स्टडी पपुलेसन चाहिँ कस्तो हुनुहुन्छ भने जो बालबालिकाहरूको चाहिँ नि स्कुलमा स्क्रिनिङ गर्दाखेरि भिजनमा समस्या देखिएको छ भने चाहिँ नि त्यो बालबालिकाहरू चाहिँ हाम्रो स्टडी पपुलेसन हुनुहुन्थ्यो हाम्रो यसमा मिक्स मेथडमा चाहिँ नि क्वान्टिटेटिभ स्टडीको लागि चाहिँ नि 310 जना हाम्रो पार्टिसिपेन्ट हुनुहुन्थ्यो भने हामीले यसमा 6वटा फोकस ग्रुप डिस्कसन गरेका थियौँ स्याम्पलिङ टेक्निकको कुरा गर्दा चाहिँ अघि मैले भने 120वटा विद्यालयमध्ये हामीले 21वटा विद्यालय छान्यौँ जहाँ चाहिँ नि परियोजनाबाट 17 जना विद्यार्थीले चाहिँ नि एटलिस्ट 17 जना विद्यार्थीले चस्माहरू चाहिँ पाउनुभएको थियो र चस्मा जसले यो परियोजनाबाट पाउनुभएको थियो हामी सबैलाई उहाँहरूलाई चाहिँ नि यो स्टडीको लागि इन्भाइट गरेका थियौँ भने हामीले त्यस्तै 6वटा विद्यालय जुन यो 21वटा विद्यालय बाहेकका 6वटा विद्यालयबाट चाहिँ हामीले फोकस ग्रुप डिस्कसन गरेका थियौँ। सन् 2015मा चाहिँ नि एउटा स्टडी निस्किएको छ। त्यो स्टडीले चाहिँ के देखाएको छ भने नेपालमै भएको स्टडी हो। त्यो स्टडीले चाहिँ नि विद्यार्थीद्वारा विद्यार्थीहरूको भिजन स्क्रिनिङ गर्ने है। यदि तपाईँहरू कोही एउटा आँखा जाँच केन्द्रमा जानुहुन्छ भने सबभन्दा पहिला यो यस्तै गरेर तपाईँहरूको दृष्टि जाँच गरिन्छ। त्यहाँ अब स्वास्थ्य केन्द्रमा चाहिँ नि स्वास्थ्य कर्मीले गर्नुहुन्छ, तर हामीले चाहिँ नि के गर्यो भने हामीले विद्यार्थी भाइ बहिनीहरूलाई नै तालिम दिएर एक दिने तालिममा हामीले उहाँहरूलाई थ्योरी र प्र्याक्टिकल दुवै सिकाएर चाहिँ नि यो भिजन स्क्रिनिङ गर्नको लागि सिकायौँ र ती तालिम प्राप्त विद्यार्थी भाइ बहिनीहरूले आफ्नो सहपाठीहरूलाई चाहिँ नि आफ्नो स्कुल टिचर अथवा स्कुल नर्सको सुपरभिजनमा चाहिँ उहाँहरूले भिजन स्क्रिनिङ गर्नुहुन्छ र जसको भिजन चाहिँ 6/12 लेस देन 6/12 भनौँ, त्यो लेस देन 6/12 भएका धेरैलाई चाहिँ नि चस्माको आवश्यकता पर्छ रिफ्र्याक्टिभ एरर करेक्सन गर्नको लागि। त्यस्ता बालबालिकाहरूलाई चाहिँ नि उहाँहरूले आइडेन्टिफाई गर्नुहुन्छ र त्यस्ता आइडेन्टिफाई भएका बालबालिकाहरूलाई चाहिँ नि हामीले नजिकैको आँखा उपचार केन्द्रमा जानको लागि सल्लाह दिन्छौँ र त्यहाँ चाहिँ हामीले परियोजना अन्तर्गत निःशुल्क ओपिडी र यो सब्सिडाइज ग्लासेसको लागि चाहिँ नि सब्सिडाइज गरेका हुन्थ्यौँ र हामीले चाहिँ उहाँहरूलाई त्यहाँ जानको लागि अनुरोध गर्थ्यौँ र यदि उहाँहरू 3 महिनाभित्र पनि जानु भएन भने चाहिँ नि हामीले अब विद्यालयमै चाहिँ नि अप्टोमेट्रिस्ट पठाएर हामीले चाहिँ उहाँ नानी बाबुहरूको चाहिँ नि रिफ्र्याक्टिभ एरर करेक्सन गरेका थियौँ र यो जुन रिफ्र्याक्टिभ एरर करेक्सन गरेका बालबालिकाहरू हुन्छ स्कुलमा अथवा क्लिनिकमा अथवा आई सेन्टरमा गएर करेक्सन गर्नुभएका छन्। ती बालबालिकाहरू नै हाम्रो चाहिँ स्टडीको स्याम्पल हुनुहुन्छ। अब हामीले यसको लागि स्टडी टुल चाहिँ नि हामीले लिटरेचर रिभ्यू र एक्सपर्ट एडभाइसबाट गरेका थियौँ भने फेस टु फेस इन्टरभ्यू गरेका थियौँ ती स्याम्पलसँग र क्वालिटेटिभ स्टडीको लागि चाहिँ हामीले एफजिटी गाइडलाइन चाहिँ डेभलप गरेका थियौँ। स्टडी सामान्य नै छ। हामीले चाहिँ नि यसमा डिस्क्रिप्टिभ एनालाइसिस पनि गरेका छौँ भने मल्टिभ्यारिएट एनालाइसिस पनि गरेका थियौँ र मल्टिभ्यारिएट एनालाइसिसको लागि चाहिँ नि हामीले सबै भेरिएबल अफ इन्ट्रेस्टलाई चाहिँ नि मल्टिभ्यारिएट एनालाइसिसमा लगेर राखेका थियौँ र क्वालिटेटिभ डाटा एनालाइसिसको लागि चाहिँ हामीले ब्राउन एन्ड क्लार्क्सको 6 स्टेप थीमेटिक एनालाइसिस टेक्निक चाहिँ नि हामीले प्रयोग गरेका थियौँ। नेपाल हेल्थ रिसर्च काउन्सिलको एथिकल रिभ्यू बोर्डले चाहिँ हामीलाई यसमा एथिकल क्लियरेन्स दिएको थियो भने हामीले सबै विद्यालयहरूबाट चाहिँ नि एप्रुभल लिएका थियौँ र प्यारेन्टल इन्फर्म कन्सेन्ट लिएका थियौँ भने यस्तै गरेर हामीले हाम्रा बाबु नानीहरूसँग पनि इन्फर्म एसेन्ट लिएर चाहिँ नि स्टडी गरेका थियौँ। अब अघि मैले भने सबैजनाले चस्मा त पाउनुभयो, तर हामीले चाहिँ यो जुन बच्चाहरूकोमा भिजन डिफेक्ट देखिएपछि उहाँहरू चाहिँ नि नजिकैको आँखा उपचार केन्द्रमा गएर जचाउनुहोस् भन्नेको सङ्ख्या जचाउन जानुहोस् भन्दाखेरि चाहिँ नि केवल 47% मात्रै चाहिँ नि आई हेल्थ सर्भिसको लागि युटिलाइज लागि जानुभयो भने यसमा पनि अझ फिमेलहरूको सङ्ख्याहरू हुन्छ, फिमेलहरूको चाहिँ नि युटिलाइजेसन चाहिँ नि पुवर थियो। अब यो नन युटिलाइजेसनको मुख्य कारणहरूमा चाहिँ के थियो भन्दाखेरि एउटा चाहिँ नि आई हेल्थ फेसिलिटी चाहिँ अलिक टाढा हुनु। अघि पनि मैले पनि भनिहालेँ नेपाल सरकारको स्वास्थ्य केन्द्रहरूमा चाहिँ नि आई हेल्थ सर्भिसेस नहुने हुनाले पनि होला यो आई हेल्थ फेसिलिटी एनजिओले चलाएको अथवा प्राइभेट सेक्टरले चलाएको अथवा मेडिकल कलेजले चलाएको चाहिँ सबै टाउन अथवा अर्बन सेन्टरमा त भएको हुनाले पनि यो चाहिँ आएको हुनसक्छ। र अर्को चाहिँ नि अरू दुई कारण चाहिँ नि यो पारिवारिक कारण र बच्चाहरू आफैले पनि जान नचाहने आँखा जाँच गर्नको लागि देखियो भने यो स्टडी चाहिँ नि कोभिड-19 को समयमा भएको हुनाले कोभिड-19 पनि एउटा नजानुको कारण चाहिँ एउटा रिजन थियो। र हामीले यदि फ्याक्टर्स हेर्ने हो भने चाहिँ नि यो अर्बन र रुरल रेजिडेन्स एउटा चाहिँ नि प्रेडिक्टर थियो भने अर्को चाहिँ नि मदर्स जब है रेगुलरली पेड मदर्स जब छ भने चाहिँ नि त्यो उहाँहरू चाहिँ नि जानुहुन्थ्यो र अर्को चाहिँ नि नजिकै अब आँखा बच्चा केन्द्र नजिकै छ भने पनि उहाँहरू चाहिँ जानुहुन्थ्यो र हाम्रो मल्टी रेट एनालाइसिसमा चाहिँ के देखियो भने रेजिडेन्ट्स अब किनकि यो आँखा बच्चा केन्द्र धेरै जस्तो टाउन सेन्ट्रिकै भएर पनि होला हाम्रो चाहिँ यो अर्बन पपुलेसन चाहिँ नि हाम्रो आई केयर सर्भिस युटिलाइजेसनको लागि जानुहुन्थ्यो र हामीले अब थीमेटिक एनालाइसिस गरेका थियौँ र त्यसमा पनि यो मुख्य तिनवटा चाहिँ के देखियो भने एउटा चाहिँ एसेसिबिलिटी टु आइएल फेसिलिटी नै भयो एफोर्डेबिलिटी अफ सर्भिसेस पनि अर्को भयो भने अर्को चाहिँ नि यो अवेरनेस कम हुने हुनाले पनि नगएको चाहिँ हामीले पायौँ अब यसलाई कन्क्लुड गर्नु पर्दाखेरि चाहिँ नि हाम्रो चाहिँ यो आई हेल्थ प्रमोसन गर्नुपर्ने देखिन्छ विशेष गरी समुदायमा पुग्ने गरी र अझ समुदायभन्दा पनि विकट ठाउँमा पुग्ने गरी चाहिँ नि हामीले आई हेल्थ प्रमोसन गर्नुपर्ने देखिन्छ र अर्को चाहिँ अब अहिले इन्टिग्रेटेड पिपल सेन्टर भनेको छ त्यस्तै गरेर यदि हामीले चाइल्डहरूको लागि फोकस गर्यो भने चाहिँ नि इन्टिग्रेटेड चाइल्ड सेन्टर आई केयर मे ओभरकम मल्टी लेयर्ड ब्यारियर्स टु द युटिलाइजेसन अफ आई हेल्थ सर्भिसेस दिज आर माई रेफरेन्सेस अनि यो चाहिँ नि हाम्रो अ पार्ट अफ प्रोजेक्ट चाहिँ नि स्टुडेन्ट्स फर युनिभर्सल आई हेल्थ कभरेज अन्तर्गत थियो र यसको फन्डिङ एजेन्सी चाहिँ नि युएसएआइडी थियो र अरू चाहिँ हाम्रो पार्टनर्सहरू छन् थ्याङ्क यू
Thank you so much, Vijay Khatri. Any questions for him? Yeah.
Thank you for the presentation. My question was with regard to the third theme that you had identified about the misconceptions about the spectacle use. So I wanted to know whether you had conducted any interventions to target these misconceptions among the students after you have identified it in your study?
We haven't conducted that yet. But we are planning to go further for next stage in this project.
Thank you. One more? It's no, then we'll proceed again. So very interesting topic again.
Thank you.
Umesh Aryal will be presenting this topic, monitoring tobacco smoking and age of smoking initiation in Nepalese population, a secondary data analysis of results from WHO STEP survey with Bayesian approach. Please, Umesh Aryal.
Good afternoon, everybody. Thank you, NHRC, for providing this opportunity to share some research here. When we talk about the tobacco control measures, there are two important variables. One, first is prevalence, and second is age of smoking initiation. And these two variables play key role in prevention and control of tobacco. Next, we have a weak monitoring mechanism, and due to the weak monitoring mechanism, we are poor implementation of tobacco control policy. And up to date, when we talk about these two variables and when we compare the results, most of the time the results are compared according to the classical hypothesis. That is based on p-value, and the p-value is widely misused in medical statistics these days, and it has sometimes it has led to the wrong conclusion. That's why this present study has approached the Bayesian approach to test the hypothesis. And using this Bayesian hypothesis, we have planned to compare the smoking prevalence rate between different STEP surveys and mean age of smoking initiation between men and women in Nepal. And this is the objectives and methods. When we talk about the methods, this is secondary data analysis secondary data were collected from 3-step survey, 2007, 13, and 19. And the STEP survey is a nationally representative cross-sectional survey carried out in different parts of the country. And it's collected especially data on non-communicable disease risk factors. In 2019, it collected the 5593 individuals from different 7 provinces of Nepal. In 2013, it collected 4,200 individuals, age group 15 to 69 years, and in 2007, it collected the information from 4328 individuals, age 15 to 64 years. And in methodology, we selected only the 3 variables: current smoking behavior, age, sex, and age of smoking initiation. And then we set up the hypothesis. Our hypothesis is to compare the smoking prevalence rate between 2008 and 19, as well as between 2013 and 19. And second hypothesis is to compare the mean age of smoking initiation between male and female using data from 2019 STEP survey. And for statistical analysis, we use both classical or frequentist approach and as well as the Bayesian approach to test the hypothesis. And this Bayesian factor were computed using the conditional probability between 2 competing hypotheses. Means usually in frequency approach or the classical approach, we compare the hypothesis against the null hypothesis, but the Bayesian approach has the opportunity to test also against null versus alternative and alternative versus null. And we also computed the credible limit that is equivalent to confidence interval. And further, we did the robust analysis called sequential analysis. That helps to monitor the sampling plan in original research design. And this is a mathematical model for Bayesian factors. It computed the both prior and posterior probability of uncertainty. Now results. This is the prevalence of tobacco smoking in Nepal from 2007 to 2019. In 2007, it is reported 26.5, while in 2019, it is 17.1%. And to test this hypothesis, first we used the classical approach and found the result. We compared between 2013 and 19 smoking prevalence rate using the one-sided alternative hypothesis, and it found the result is not significant between 2-step survey 2013 and 19. To confirm these findings, we further did the computed the base factors and found that if you see that the figure, that is called the prior posterior plot, and from the figure there are the dashed line indicate the prior probability, prior prevalence, and line indicate the posterior probability, and it indicates that the prior line is below the posterior line indicates that the results are in favor of null hypothesis, and the base factors value is 56.59. It indicates that the data were 57 times more likely to produce result in favor of null hypothesis compared to then alternative hypothesis. And this is the robust analysis. This robust analysis proves that there is there is in favor of strong evidence very strong evidence in favor of null hypothesis. Because the figure clearly indicate that if the value is above 1 and showing the most of the data are following value above 1 indicate the in favor of null hypothesis. Next, we also compared the smoking prevalence rate between 2007 and 2019. It said that there is significant difference in reducing the smoking prevalence rate in Nepal between the 2007 and 2019 with effect size of 0.19. And it proved, the figure, the prior and posterior plot proved that results are in favor of alternative hypothesis. And there is a base factors value is very small, indicate data are extremely more likely in favor of alternative hypothesis under null hypothesis. And this is also provide the evidence that all the value are below 1, indicate there is a strong evidence on under null hypothesis.
You have
Sorry,
2 minutes more.
Okay, thank you. Next, we compare between the age of smoking users. Since the data are skewed, so we transferred the data into log transformation and did the analysis. The analysis found there is no difference in smoking, there is no difference in smoking initiation rate between male and female. And the robust analysis also proved that the data support strong evidence towards null hypothesis. And further also we did the individual data analysis for using this robust analysis, and it also indicates there is strong evidence towards null hypothesis. And I would like to conclude. Our findings suggest that between 2007 and 19, the smoking prevalence rate is declined, but between 2013 and 19, there is no decline in smoking prevalence rate, and this is a questionable. Why the smoking prevalence rate is not declining in last 5 years? And this is to be aware, this is to be create awareness to the policymakers, and what is the cause behind this stationary smoking rate in last 5 years. Thank you very much.
Thank you so much. We can take 2 questions for him. Already tired, so we can move forward. Next topic will be presented by Bikram Adhikari. The topic is Non-Communicable Disease Service Readiness in Nepal, a further analysis of Nepal Health Facility Survey 2021. Please.
Good afternoon, everyone. Our respected chairs, distinguished guests, our panelists, all the members present here in the summit. It is my privilege to address you all in this 9th National Summit organized by Nepal Health Research Council. And I would like to thank Nepal Health Research Council for providing me this wonderful opportunity to present on our research with the topic Non-Communicable Disease Service Readiness in Nepal, a further analysis of Nepal Health Facility Survey 2021. And I would like to thank all the members, team members from HORD International who contributed and supported me for this research. Without any delay, I would like to continue and begin my presentation. Non-communicable diseases, they are the major public health issue throughout the world. And it is also a leading cause of premature mortality and disability adjusted life years in Nepal. In one hand, the burden of the NCDs, they are rising, and it is not matched with the availability of resources and appropriate healthcare response as well as the healthcare utilization. And there is a need to generate the evidence to uncover gaps in NCD service readiness to facilitate the evidence-informed policy making to improve the service availability and uptake. The major objective of this study is to assess the readiness of the health facilities in delivering the different NCD-related services like cardiovascular disease, diabetes mellitus, chronic respiratory disease, and mental health-related services in Nepal. We performed secondary data analysis from Nepal Health Facility Survey 2021. And the Nepal Health Facility Survey 2021, it was the second nationally representative survey of health facilities, and it was implemented by New Era with the technical support from ICF International. Talking about the sample size and sampling, a total of 1,633 health facilities were selected from the eligible health facilities using probability systematic sampling technique. And out of the total selected health facilities, the successfully survey was taken from the 1,576 facilities, and in our secondary data analysis, we are using the 1,487 facilities who provide NCD-related services. The independent variables involved in our study involves the characteristics of the health facilities, which include settings, ecological region, province, type of facility, presence of external supervision in past 4 months, quality assurance activity, presence of the quality assurance activities, review of client opinion, and frequency of health facility meeting. The dependent variable, it involves the readiness score. The readiness score was measured based upon the WHO Service Availability and Readiness Manual. For calculation of the readiness score for each NCD's related services, there are the treasure items treasure items that were classified into different domains. The domains include staff training and guidelines, essential equipment and supplies, medicine and commodities, and diagnostics. And the treasure items, they were coded into 0 or 1 based on the availability or functioning of those treasure items. And the score for each domain was calculated and in 100%. And average of the domain, average of all domains that are taken for calculation of the readiness score, it was the overall readiness score. And the facilities with the readiness score of more than 70, they were considered as the ready facility to provide NCD-related services. These are the list of treasure items for different NCD-related services. We use R for statistical analysis, we use QGIS for mapping, and we performed weighted descriptive analysis and inferential analysis. And in descriptive analysis, we presented mean and standard deviation for the parametric variables, whereas the median and interquartile range for non-parametric variables. And in inferential analysis, we calculated 95% confidence interval around the proportion, and univariate and multivariate logistic regression analysis were carried out, and the result of the regression analysis was presented as odds ratio, and it's 95% confidence interval. For this secondary analysis, we sought no ethical clearance, but the original Nepal Facility Survey 2021, it was approved by the NHRC as well as ICF International. Now let's come to the result part. Out of the total facilities offering NCD-related services, only 26% of the facilities, they have mental health-related services. And the facilities with the CVD-related services were 93.1, with the diabetes mellitus-related services were 75.8, and for chronic respiratory disease-related services, it was 99.3%. Now, this table shows the readiness score domain-wise as well as overall readiness score for each of the NCD's related services. The median readiness score for CVD-related services, it was 35, and for diabetes mellitus, it was 35.4, and for chronic respiratory disease related services, it was 26.7, and for mental health related services, it was 18.8. Looking over the different domains, the guidelines and the staff training, it is found to be the weakest part with the score less, it is less than 20%. As we have classified those facilities with the readiness score more than 70 as ready facility to provide the NCDs related services, 3.8% of the facilities with the cardiovascular disease-related services are only ready, or they have a score greater than 70. And for the list, 2.3% of the facilities offering chronic respiratory disease-related services, they were ready. And for mental health-related services, only 3.3% they were ready. And for diabetes, it was 3.7%. Here it is a Gardner and Altman plot comparing the readiness score by province for each of the NCDs related services. And it shows substantial difference in readiness score by province for each of the NCD related services.
You have 2 minutes more.
Okay. Here this shows the facilities offering more than 70, the facilities with the readiness score of more than 70 by the type of the health facility. Among the federal or the provincial hospitals, the ready facilities, they are, the percentage ranges from 13.4 to 22.6, and among the peripheral public health facilities, the facilities that are ready, it ranged from 1.5 to 2.9% for 2.9%, and it shows that for each of the three different type of the health facilities, it is ready facilities are really very low compared to what is needed. Here this map shows the facility-wise and district-wise readiness score for different entities related services. Here, this table is the multivariate logistic regression model to determine the association of the health facilities offering CVD-related services with the characteristics of the health facilities. And here the facility is higher odds of having the facility to be ready was seen in the rural areas compared to urban, and in the facilities that has the provision for revision of client opinion. And it was the odds of the mountain region, they have the less likely to be ready. The facilities from mountain region, they are less likely to be ready compared to hill. And similarly, from the Madhya province, they are less likely to be ready for the CVD-related services. Here in this table, the facility with the external supervision, they are more likely to be ready to provide COPD, chronic respiratory disease-related services. And the facility with the external supervision, they are more likely to provide, they are more likely to be ready to offer the diabetes mellitus-related services. And the peripheral public health facilities, they are less likely to be ready compared to the federal and the provincial hospitals. Similarly, the local hospitals, peripheral public health facilities and the private hospitals, they are less likely to be ready compared to the federal and provincial hospital in providing, providing the mental health related services. While comparing the data from Nepal Health Facility Survey 2016 and 2021, there is a substantial increase. There is an increase in readiness of each facilities to provide different three of the entities, that is cardiovascular disease, diabetes mellitus, and chronic respiratory disease. But mental health related information that was not collected in 2016. So there is no information. There is increase, but the increase in the readiness score for these services, it has increased, but still there is a scope to improve on them. In conclusion, the overall readiness of the facilities to provide ancillary-related services in Nepal is suboptimal, and peripheral facilities, public health facilities are less likely to be ready compared to federal and provincial hospitals, and it is essential to enhance service delivery platform and enhance the overall readiness of the health system to provide ancillary-related services by increasing the number of qualified health staffs, providing training, and supplying equipments and the medicine. Thank you.
Thank you. Thank you so much. Since we are running out of time, I would like to invite the last speaker of this session, Anshu Raj Dahal. It was announced earlier, Anshuji. The topic is prostate cancer in male and breast cancer in female make the largest cancer pool in the world.
त्यो PDF ओपन भएन इमेलमा छ अहिले इनबक्स डाउनलोड गर्नुपर्छ होला यो हैन डाउनलोड गर्दैछु खै PowerPoint हो
खास यो चाहिँ एउटै फोल्डरमा राख्नु सबै Okay.
Good afternoon. Today I am presenting a topic called prostate cancer in male and breast cancer in female make largest cancer pool in the world and in the EU 28 plus EFTA. I'm sorry that I included EU 28 now. In the Department of Radiation Oncology, University Hospital of Bonn. The basic motive of me presenting these slides in here is I'm trying to research, especially in cancer. She was working in the breast cancer model, and we want to go into the prostate cancer. So she told me to search for evidences. What are the evidences that we must prove for our research in prostate cancer? So I decided to work on this, and I started searching in PubMed, and then we felt little attention given to prostate cancer. And we wanted to show that both of these cancers make the largest cancer pool in the world, and this issue should be brought in limelight. Several of the databases were used during the research process, such as NIH, SHEER, European Cancer Information System, Global Cancer Observatory, and Centrum for Krebsregisterdaten, or it's Deutsch German Data Center for Cancer, and Robert Koch Institute. Here, in the result, out of which are the evidences for this prostate cancer and breast cancer, they were altogether almost like more than 20,000 research articles related to breast cancer and less than 10,000 articles or indexed published research materials in prostate cancer. So this was a pretty good evidence that we can go in depth in researching the condition of the prostate cancer. And in the in the report by GlobalCan in 2018, the new cases, out of total new cases, the 11% belong to breast cancer and 10% is for prostate cancer. And and in EU FTA itself, the incidence rate was for breast cancer 145 per 100,000 and 160 per 100,000 for the prostate cancer. So here are the evidences that I can present it to you. in the above figure, we have breast and prostate, which makes the largest cancer pool. Similarly, the condition is similar in EU 28 plus EFTA, where the prostate and breast cancer creates the largest cancer pool in the world. So a little bit more in depth, what is showed was this cancer is even evident in the age group of 15 and 19. You can see in the slide, which is pretty much worrisome because this, we also found some evidence that in this group, the cancer is more aggressive and the treatment is sometimes impossible and hard. And the other evidence we got from the Cancer Research UK database was there was a substantial increase in earlier onset of the prostate cancer, especially in the age group of 25 to 49. The rate of incidence increased by greater than 400% since 1990s. So this pretty much sums up everything. Like, are we like neglecting prostate cancer and only like caring for the breast cancer? Because worldwide, PC and prostate cancer and breast cancer account for the largest cancer incidence. Mortality from both the cancer is also on par with the leading site-specific cancers. A lot of research and publications have been done on breast cancer. So fewer efforts in relation to prostate cancer was made, especially when the cancer incidence in the teenagers has become common. Both the prostate and breast cancer contribute about half of all the cancers in the oncological pool. And thank you to my professor. This was all from my side. Thank you.
Thank you, Ansuji. Please have a seat on the dais here yourself. Questions to him? One or two questions we can take.
Just I'd like to ask, what is your further plan, on the basis of your preliminary study? So what you're expecting to do further?
This was a preliminary study. I actually worked in the world now tells it's a precision medicine, but we worked on the on innovative medicine approach, which is called predictive diagnostics, targeted treatment, and personalization of medical services. After we found the evidence, then we moved into the next phase, and I worked on the thesis title called Scientific Evidence for Shifting the Paradigm in Management of Prostate Cancer from Reactive Medicine, that is a present medicine, to a personalized therapy. So that was.
Thank you. Thank you for exhausting but excellent presentation to all the invited speakers and presentation. I think we now end this session, and I now hand over the mic to the Master of Ceremony. Please proceed.
Thank you, chairs, guest speakers, presenters, and all the participants for this wonderful session. We are now nearing to the end of this session, and now I humbly request our chairs, Dr. Bhojraj Adhikari and Professor Dr. Sujan Babu Maratha, to distribute token of love to our speakers. Dr. Sabitri Sapkota, Dr. Biba Simkara, Dr. Lamo Yonchan Serpa, Mr. Nicholas Turk, Dr. Krishna Aryal, Professor Om Kurmi, Dr. Ansuraz Dahal, Mr. Bizay Khatri, Mr. Umesh Aryal, Mr. Bikram Adhikari. Thank you, chairs. Now I would like to request our chairperson to distribute token of love to our chairs. Chairperson Dr. Gehenath Baral, please come up on the stage and distribute token of love to our chairs. Now I humbly request all of our, sorry. Now I humbly request all our speakers, presenters to stand on the stage for a group photo with our chairs and chairperson. Thank you once again for this wonderful session. Thank you for your indispensable presence and patience.
Hello, I request everyone outside to please be seated in their respective halls for the parallel session. I repeat, everyone outside are requested to be in their respective halls for the parallel session. Good afternoon and a hearty welcome to you all in the third session of 9th National Summit of Health and Population Scientists in Nepal, organized by Nepal Health Research Council. I am Dr. Pratibha Subedi, and I'm honored to be your Master of Ceremony for this parallel session on biomedical and translational research. This is going to be an interesting session with diverse topics that fundamentally focus on bridging the gap between knowledge gained through research and its applications in policy and practice. Without further ado, may I now take this opportunity to introduce the chairs for the session. I'm honored to invite on stage respected Dr. Janak Koirala as our session chair. Dr. Janak Koirala is a professor of medicine and infectious diseases at Patan Academy of Health Sciences and clinical research consultant at Nepal Health Research Council. Additionally, he serves as a professor emeritus and former division chief of infectious diseases at Southern Illinois University School of Medicine. With over 2 decades of experience in clinical research, he has authored over 60 peer-reviewed scientific publications in international journals and has also presented on several national and international forums. He has led multiple studies in Nepal as a country PI, including WHO's Solidarity Plus trial for treatment of COVID-19. Dr. Koirala is a fellow of American College of Physicians and a fellow of Infectious Diseases Society of America. He currently serves as an executive member of the Global Health Committee of Infectious Disease Society of America. Next, it is my utmost pleasure to invite our second chair, Dr. Anu Bastola. Dr. Bastola is currently the Director in Curative Service Division of Department of Health Services. He previously worked as a Chief Consultant, Tropical Medicine Physician at Sucraras Tropical and Infectious Disease Hospital. He has over 16 years of experience in the field of medicine. He's a member of International AIDS Society and American Society of Tropical Medicine and Hygiene. In addition, he also serves as a member of CRO Technical Advisory Group on HIV, hepatitis, and STI, as well as rabies. Dr. Bastola has more than 50 scientific publications and has been involved in the formulation of several national guidelines regarding infectious diseases. He has been awarded with multiple honors, including Supraval Janasewa Shri 3 by President of Nepal and Barbara Foundation COVID-19 Special Honor for his excellent contribution in treating and preventing the spread of coronavirus. It's my enormous pleasure to have both of these scholars as our session chair. We have a total of 12 speakers in this session, including 1 keynote speaker, 4 invitees, and 7 presenters. I would like to inform you all that our keynote speaker, Dr. Manju Rani, shall join us virtually. She has provided us with a recorded presentation and shall be taking questions in the question and answer session. May I now invite on stage all the presenters of the session. Dr. Archana Shrestha, Professor Dr. Rita Thapa, Ms. Kriti Lamichane, Mr. Jhabindra Bhandari, Dr. Rabha Thapa, Ms. Usha Ghimire, Ms. Kritika Dikshit, Ms. Sulata Karki, Dr. Abriti Arjal, Dr. Indra Bahadur Napit, and Dr. Sandeep Srivastav. Thank you, all the speakers. Moving forward, I would like to inform that all the presenters shall be given 10 minutes for their presentation, and questions shall be addressed by the respective presenters at the end of their presentation. Without further delay, I would like to hand over the session to our session chair. Over to you, chairs.
Thank you. Good afternoon. It's close to actually good evening. So we have a number of presentations, as we heard. So without any further delay, I'd like to welcome you all to this parallel session for biomedical and translational research. Our first speaker is online. She's already with us. It's Dr. Manju Rani. So for introduction, Dr. Manju Rani is currently the Regional Advisor for Research and Innovation at WHO Regional Office for South Asia at Delhi since January 2022. Let's put up her picture if we could, or her video. Since 2004, she has held different positions at different WHO regional offices, covering several public health issues, including immunization, prevention and control of hepatitis B, health research and strengthening of health systems, and prevention and control of non-communicable diseases. She was also part of World Development Report team in 2004, a flagship publication of World Bank. She has also worked in public sector in India in several leadership positions at district and state level, and also contributed towards an initiative on assessment of essential public health function in India. She received her MBBS degree from Delhi University in India, PhD degree in public health from Bloomberg School of Public Health, Johns Hopkins University in the United States. I would like to welcome Dr. Manju Rani. Please go ahead and start the presentation for Dr. Manju Rani, and she'll take the question at the end. Thank you. Can you start the presentation for Dr. Manju Rani? के भएन यहाँबाट Dr. Manju Rani, I think they're waiting for your live presentation because the recorded presentation didn't work. So you can upload your slide and start your presentation. Yes, you can share your slides if you have it on your computer.
Okay, just give me a few minutes.
Yes, yeah, please go ahead.
Just say the host has disabled the participants from sharing.
Can you make Dr. Manju co-host? So I think we'll move to the next presentation when the online presentation is being fixed. Is that possible? Okay. Yeah, so our next speaker, I'll pass to my co-chair.
Thank you, Dr. Janak. Good evening, everyone. Welcome to the session. So our next speaker is Dr. Archana Shrestha. She is an associate professor at the Department of Public Health, Kathmandu University School of Medical Science. She is an adjunct faculty of AL School of Public Health and an executive director at the Institute of Implementation Science and Health. She has received her PhD in epidemiology from the University of Washington and did postdoctoral fellowship in implementation science at Harvard University. She has been working in Nepal for the past 15 years on building capacity and conducting research on NCDs, particularly focusing on nutrition, health promotion, and implementation science. Let's welcome Dr. Archana. Please go ahead. You have only 10 minutes, okay? Thank you.
Hello. Okay. Thank you, Dr. Anup, for the introduction. Today I'm going to talk about evaluation results of package of essential non-communicable diseases in Nepal. This was an implementation study conducted with a joint venture of Kathmandu University School of Medical Sciences, Nepal Health Research Council, Yale School of Public Health, Emory University, and World Health Organization. And here are the team members. Let's start with the introduction. NCD contributes to 71% of the global deaths, and 66% of the total deaths in Nepal in 2018 was due to NCD. CVD is the #1 cause of death globally, and 31% of all global deaths. COPD attributes to 5% of all deaths, and cervical cancer is the most common cancer among women in Nepal. Together, these NCDs in LMIC cost about $500 billion per year. In order to avert this effect, Global Action Plan for Prevention and Control of NCD was introduced 2013 to 2020. That came up with the interventions that were called best buys, which are the cost-effective interventions for prevention and control of NCDs, specifically focusing in low-resource setting. In Nepal, WHO adopted the PEN that incorporate all of the best buys protocol in 2016 and gradually expanded to all districts by 2022. This is the glimpse of PEN in Nepal. We have prevention of heart attack, stroke, and kidney diseases as the first protocol. Second protocol is the counseling on lifestyle modification. Third protocol is about the management of asthma and chronic obstructive pulmonary diseases. And the fourth protocol is on early diagnosis of cancer that includes breast cancer and cervical cancer. Let's come back to this study. We had two specific objectives. One was to evaluate the implementation of PEN in Nepal, that we looked at acceptability, adoption, feasibility, fidelity, penetration, sustainability, and the cost. And second objective was to identify factors that were facilitators and barriers to PEN implementation at the health system and community level. And I'm going to present a part of this study. Initially, we formed a national task force for the evaluation that consisted of representatives from Nepal government, WHO, KUSMS, and Yale School of Public Health. This was an explanatory mixed methods study. We did assessment of the implementation of PEN through quantitative survey in health facilities, and then supplemented that with exploratory exploration of perceived facilitators and barriers to PEN, and as the results were interpreted together. For the quantitative survey, we went to all 7 provinces. 2 districts per province was randomly selected, and from each district we conducted a proportionate random sampling stratified by location from urban and rural areas. So altogether we included 105 health facilities. These were the survey sites. For the qualitative study, we conducted 104 qualitative interviews at central, provincial, district, municipality, and health facility level. That included health authorities, healthcare providers, as well as NCD patients. The data collection was done in person in each of the health facility using a questionnaire developed based on WHO's SARA tool. And then descriptive statistics were calculated. And for the qualitative methods, we included key informant interviews and conducted thematic analysis. This is the status of general services as primary healthcare services in the sample health facilities. Overall, 35.6% were providing emergency care. 81% had counseling, room with audiovisual privacy. In terms of pain training session, 50% said that the training duration was adequate, and as I mentioned earlier, we integrated both qualitative and quantitative results. So one of the ITIs stated that the time duration and content of the training was limited. While talking about the pain-trained personnel, overall 67% of the health facilities had at least one pain-trained personnel. There were more pain-trained personnel in the primary healthcare setting compared to health post. For the diagnosis and management of diabetes mellitus and cardiovascular diseases, blood pressure machine was available in 96% of the health facility. Glucometer was available in only 43% of the health facilities. For the diagnosis and management of chronic respiratory diseases, 98% has stethoscope, 12% has peak flow meter, only 5.6% has spacers for inhalers. For the cervical cancer screening, national guideline still accepts visual inspection with acetic acid. Overall, there was 62% of the facilities that had availability of the speculum to conduct this test, but only 15% had acetic acid. While talking about the essential medicines, we can see that the essential medicines were available in the primary healthcare settings much more than in health post setting. It was more due to linkage with national health insurance. The PSCs where there were more national health insurance was implemented, the medicine availability was more. Only 18% said that they regularly conduct the CVD risk estimation. That is one of the protocols for the PEN one. Regarding the recording and reporting system, only 17% had NCD OPD cards and only 19% had NCD registers, and most of the health facilities interviews suggested to integrate NCD service, NCD recording reporting into the regular HMIS system. Only 14% reported to have ever having monitoring or supervision visit in the past year. So I'm going to give a little bit brief about facilitators and barriers from our qualitative findings. In terms of facilitators, social health insurance coverage was one of the primary facilitators, as it contributed to availability of medicines. That was also one of the major factors for positive plan implementations. The health service providers' motivation, physical and cultural proximity of the patients from the health facilities, PEN orientation and peer coaching sessions. After the training, after a health personnel gets training, they were supposed to go back to their health facility and conduct peer coaching sessions. So in the health facilities, those who were conducting the peer coaching sessions, these sessions were considered as facilitators. Health service providers' readiness to integrate NCD services, that means that how they perceive readiness of their specific health facility to implement the NCDs. Again, the social health insurance implementation. So we have two. One is the coverage. Larger the coverage was better, and whether or not the health facility had social insurance also had a positive impact. Empowerment of local government units had also had a huge facilitating factor, because they were contributing financially and technically.
2 minutes.
Thank you. Financially and technically to the PEN implementation, optimizing of existing resources, and community engagement programs were other factors. These were the first barriers to PEN implementation. One was the health illiteracy of the NCD patients themselves. Second, that came up a lot was excessive workload of health professionals at their health facilities, because they were now trying to juggle their ongoing responsibilities with added NCD responsibilities. Another was the weak care infrastructure in terms of referral services. Service disruption due to COVID-19 was also a major factor. Delays in training, high staff turnover, specifically those who were hired in contract, inequitable distribution of resources between and within the health facilities was another factors. And then COVID-19 also added to the workload of the healthcare providers. There were inadequate medical supplies, inadequate distribution of other resources, a poor recording reporting system, and poor coordination within the federal structure that were also contributing towards as a barrier to PEN implementation. So with that, we'd like to conclude that the PEN implementation in Nepal was not happening as expected, both in terms of their coverage and availability of the services, readiness at the health facility level, as well as we identified many barriers to PEN implementation. So future resources and research should focus towards improving this. Thank you very much.
Thank you, Dr. Archana. To all the participants, if you have any queries, comments, please note it down. We'll take few of those in the last in the session. So I just wanted to highlight some of the points, like recently, Government of Nepal has developed PEN Plus packages, and the expansion of PEN packages is going in a rapid way after COVID pandemic. Thank you for your presentation. Now we'll move to next presenter.
So I think we'll try to get back to Dr. Manjurani again, because of the technical difficulty we couldn't do it earlier. So are we going to play the presentation now? Okay, go ahead please. Thank you.
So I have shared the screen. Thank you, Dr. Parani. Is it visible? Yes.
Yes, we can see it. Thank you. Please go ahead, ma'am.
So maybe without further delay, I will just start it. First of all, thank you to National Health Research Council of Nepal for giving me this opportunity to share some thoughts about approaches to translation of evidence and innovation. As I was introduced already earlier, I'm the Regional Advisor for Research and Innovation based in Delhi in India, in the Regional Office of WHO Southeast Asia. So, first of all, why should we talk about translating the research or evidence? Because the reason we are doing the research or trying to find new knowledge and solution is to improve the public health. We have several goals and targets, including the Sustainable Development Goal, which aspires for universal health coverage by 2030. In WHO, we have also set up the triple billion goal, where we have 1 billion benefiting from universal health coverage, or 1 billion enjoying better health, or 1 billion people protected from the health emergency. But achieving all these goals with the tools we have, or what we are doing currently, may not take us there. So we need to have more evidence, more new things, more solution, but also to translate that into action to bring these public health benefits. In our regional office, the way we are trying to get jump started on achieving the health outcomes is basically sustaining what we already know has worked and has been implemented and achieved. Because none of the public health gains are permanent. We stop the immunization today, all the vaccine preventable diseases that have been controlled can come back. So we have to sustain what has worked and what is being implemented and continue to do that, but also accelerate. And that is where the role of translation will come. So accelerate where we already have the knowledge, but they have not yet been implemented or translated. So we have to accelerate the implementation of the intervention that are shown to be effective but not fully implemented. And I'll be counting on several examples. For example, we have a vaccine available for cervical cancer for more than 2 decades now, but it's still not fully implemented, and we'll discuss what are the translational barriers there, and then innovate. So innovate where we still don't have a solution, and we are facing now increasing antimicrobial resistance. We are having like a persistent infection like dengue, where we still do not have any treatment, and we just rely on a symptomatic treatment. So there are still areas where we need the innovation and find new solutions. And research is the only way, or innovation is the only way, as I mentioned, as a key to bridge the health gap of the millions. And this is one of the core functions of WHO, as well as a constitutional mandate to support the research and innovation. In 2018, and I think Nepal, somebody from Nepal must have been a member of that committee where we developed the regional research strategy for 2018 to 2022, and we are in the process of actually developing a new one. And there we said the mission is to harness the partnerships, to science, technology, and knowledge to translate. So it's not just doing the research that is enough, but it's translated into product, policies, and practice. And that is a core of my presentation today, which I will tell you later. And in this translation and the new research is happening in our regional context, which is very, very important to understand what translational barriers we may face. Seattle is a unique region where we have highest number of countries with positive economic growth, as well as one of the highest proportion of the people who are living in poverty. And there is a lack of access to care, while at the same time we have state-of-the-art healthcare present in many hospitals. Southeast Asia also has one of the lowest government expenditure and highest out-of-pocket expenditure. At the same time, it is the biggest manufacturer of many generic medicines, which has made access to medicine much more easier than in many other countries in the world. So it is a region of contradiction, and also why certain solutions are still not being implemented, despite having a very positive ecosystem in some ways. And this is one of the key core slides after the introduction, that why we are talking about translation. So I won't talk about this part, the first one. Let me see if I can get a pen. So we won't talk about this part, which is about facilitating the research, which is needed to develop the product. So the outcome of the research can be development of a new knowledge or the evidence, or a new better biomedical tool. I'm talking about the biomedical research. There can be a new diagnostic, like we have now the HPV DNA to diagnose the cervical cancer, or we have better diagnostic tests for tuberculosis. Earlier we only relied on microscopy. So it can be a new knowledge and research which led to development of a product to diagnose a disease or to prevent a disease. We are developing new vaccines. When I was studying in my medical college, we didn't have a vaccine for hepatitis, we did not have vaccine for cervical cancer or pneumococcal or rotavirus. But now with the research and advances, we do have now vaccines for many diseases which can be prevented. How to treat a disease. One of the recent example is hepatitis C, where the treatment not only became available, became very affordable as well. So these new medical products can be all products. So one of the outcome of the research may be a product. Then another one is a policy. So the research can be about how to deliver services better, like my previous speaker mentioned about evaluation of the pen package. So then it can be a product like how to deliver service in a better way, or how to finance a service better way. We have the financing model or insurance model. Like Nepal has introduced the health insurance, and there may be multiple models to do that. Or prevent a disease. So we are talking about increasing taxes for tobacco or alcohol or marketing bans. So that is also an outcome of the research that showed us that these tools work. And these lead to development of a policy, the second P, the outcome of a research which get translated. So say for example, Nepal says that we have developed a policy, a tobacco control policy, where we raise the taxes, or we have now a multi-sectoral national action plan for NCD, where we will put all the advertising and marketing bans for alcohol. So that is already the research has been taken up to make that policy. Right? So that was the first translation step. The other product of research is how to organize the clinical pathways of the care, or using different combination of drugs and care. So what is the treatment regime for tuberculosis, or what is the best doses, or the immunization schedule for a particular vaccine. So these are all clinical pathways and all, and this get translated in the form of development of clinical care protocols and guidelines. So I'm talking about the translational pathways. So we translated the research outcomes which became into a product, policies and practice. So these are the 3 P's of the first step of translation. But is the work of the work or the research benefit is okay as long as we have as soon as we have a product, policy or a practice? No, it may still not translate into a public health benefit. So we need a second step of translation. Just see. Is it visible now? Yes. So in the second stage of the translation, we have to translate this product, policies and practices into a public good. And when we say a public good, means these products, whether this is a drug or a vaccine or the diagnostics, are accessible to all who need them. Our definition for a universal health coverage.
Excuse me.
Until this product.
Excuse me. Your slide didn't advance.
Still showing that for translation step 1.
Yes. Still showing step 1.
Let me see if it is sometime it. Just give me 1 minute, because sometimes it takes time to progress further.
Yeah, maybe you can try stop sharing and start again.
Just start. So let me just try again.
Yes, we can see it now.
Okay. So basically, in the step 2, as I mentioned, we have now, maybe somebody was working in a lab for years to develop a new diagnostic test for tuberculosis, or how to diagnose HPV with DNA. Now that has become a product that got marketed, and it has been developed, but it still health expenditure on health. Accessibility. It may be the, now it is there, the government has made a policy to vaccinate everyone, and some of the vaccines which have been introduced decades ago, the coverage still remains low. It is still not available to everyone because we have problems with the delivery systems as well as the demand side barriers. People may not see the value of some of these products. And then of course the quality. So these are the translational barriers I mentioned is about the product. For a policy, so based on the research outcome, many member states may formulate a policy. But unless until it is fully implemented, the public health benefits of that research are still not there. So we may have barriers of first getting the communication to all the stakeholders, because they become aware of existence of the policy, the acceptance of that policy, and appropriateness of that policy, the delivery. Whether we might make a policy, but we do not set up the commensurate, the delivery systems to implement that policy, and then affordability. We have many policies which are developed, articulated, announced, but remains unfunded. That becomes another barrier to accessibility. So these are two stages of translation of any research evidence, that it first need to become into the one of the P's, the product, policy, or practice. The second step, the next step, is to make sure that these get implemented and get delivered to the person who are in need, to make it into a public good. Let's hope it moves. So my next slide basically summarizes the I don't know why this is getting stuck.
Yes, you may have to try the same thing again because it's not showing up.
Yeah, let me just do that. In fact, that was the reason I sent a recorded one.
Here they are. We see the same slide again. You may have to advance it. Time's up.
I might have to do it in a because when I put it in a presentation mode, sometimes it doesn't move further. So basically, now my next slide summarizes the whole idea that we have the precursor to facilitate the research itself, which will lead to development of this product policies and practices. And further, we will have the barriers to do the research to the public good. Is it visible now or not?
Yes, we can see it.
So here I demonstrate with the help of an example that for translating any research evidence, what intervention may be required. And that intervention will depend upon what is the key barrier to the translation. Is it there's no product? For example, we do not have any treatment for dengue right now. So there, the intervention has to focus on the availability. Maybe we need to fund more research to try out new molecules and the new compounds, or repurposing of the existing drug, whether some of them can work against dengue. Whether we have a drug available but it is too expensive, there we need an affordability intervention. So recently when the drugs for hepatitis C became available, initially they were very expensive expensive. It was costing almost 100,000 USD for an intervention. And here the affordability intervention doesn't mean just the making more money available, but rather it may mean that, more generic manufacturers came in. There was more public-private partnership. So there were a lot happening on the other side to how to make these drugs accessible and affordable to the masses to have the public health impact. And then again, it may be affordable, but it's still again not accessible. And there we need the accessibility intervention, which may mean dealing with the demand side factors as well as the supply side factor. And finally, you may have a thing like we have the pap smear, which was there for 2 decades, but it was not acceptable to the women. They still don't feel very comfortable with the intervention available. So how do we make it either more acceptable or talk about how to move it forward? So some more examples which we have is that now the new tests for detecting latent TB have become available in the market at affordable price. So how do we make them more integrate into the program as fast as we can without much delays? Or having the new dengue vaccines registered on all the countries on a common dossier. These are again some of the translational approaches for a faster uptake. Like how do we simplify the regulatory process? How do we improve our supply chain? So we sometimes do not think them as a part of translation, but these are all parts of the translation and the chain of translation in this. And I already mentioned some of these examples before. And how WHO is monitoring the drug, the research and innovation.
Sorry for interruption, Dr. Manju. Can you summarize? We're running, late. I'm sorry about that, the technical difficulty, but if you could summarize,
research and innovation
that
is
would
the
be great.
third
Thank
pillar
you.
for this. And there WHO is closely monitoring that new TB vaccine because we still do not have a solution. We still do not have a tool to prevent tuberculosis. So WHO is monitoring the candidates in the pipeline, the candidates in the market but not yet evaluated, and also the technologies which are under evaluation. So these are again our effort to support the innovation but also quickly bring them to the masses who need it as a part of our translational effort. And similarly, as I said, we have to continue to find new solutions. So in CRO, recently we did a health research call where we tried to find new solutions for some of the persistent challenges we are facing in management and control of the non-communicable diseases. For example, for hypertension, which is almost 20 to 30% of the adult population have hypertension, but our treatment coverage remains still around 10%. We have the medicines, we have some of the tools, but still the coverage is not very high. So this is also a translational issue. So we were looking at some of the solutions. And again, it may require further operational and implementation research, what we may do to make those 3 Ps into a public good. And CRO, as I mentioned, these are my last 2 slides, they have several advantages in promoting the quick translation of some of the research and innovation advances. It has a large population base. So it can provide lot of the volume, the sample sizes to test out the new drugs quickly and introduce them quickly. We have a lot of partners working in the region, and there's a lot very strong governments, very strong system where we can have the new innovations adopted by the National Control Program. And it may require advocacy both at the national and the international level. So historically, again, just to summarize, we have faced some late translation, delays in translation of the results of both the local research as well as the global research applicable to the countries. And it will require a lot of political advocacy, dialogue, and other measures, which I just mentioned, the wall of barriers. We have to deal with, identify each of those barriers and work on that to translate and bring the public health benefit of that research and innovation. So I think with this, this is my last slide. Thank you so much, and I'm sorry for this technical glitches, and I'm happy to take any questions and the feedback or suggestions. Thank you so much.
Thank you, Dr. Manjurani, for that excellent presentation highlighting WHO's regional research priorities as well as talking about the translation of research and evidence for public good. If there is one, I think we don't have time, so we'll take one burning question. Anybody has any burning question to Dr. Manjurani? We'll take one question. And I don't see any. So again, I'd like to thank our keynote speaker, Dr. Manjurani, and we'll move to the next speaker. Our next speaker is, again, a very well-known figure, respectable figure, Dr. Rita Thapa, who was also tied up with the CRO, the regional WHO office in the past, and she has gracefully come here to present on empowering school adolescents to prevent gender discrimination and sexual harassment, evidence from quasi-experimental study. Dr. Rita Thapa. Can you give the microphone in?
Bhaskar Tejasri Memorial Foundation, and I'm speaking on behalf of my colleagues. There's a very efficient team with me. I hope you can see my slides. Okay, now I can see better here. Okay, you know the title. I don't want to waste time on that. And next, please. And the team, I'm speaking on behalf of my very, very efficient team. I don't want to take all their names, as you can read it. So this study, Tejasri Initiative for Empowerment of School Adolescents for Prevention of Sexual Harassment, is conducted in honor of human rights advocate, late Tejasri Thapa, to advance her legacy of justice for the most powerless people. Now, as we all know, children are among the most powerless. Our study shows 12% of school adolescents suffer sexual violence, and 22% of them suffer psychological violence. So it is also related to mental health, which are immensely increasing in our society. And it all starts with the gender inequality and continue into adulthood and beyond. As you see, the twin problems, gender discrimination and sexual harassment, they are twin problems. They go hand in hand, almost shadowed. There is another study which shows out of 472 cases in 5 years in the register in the High Court of Lumbini, the famous Lumbini province, shows that very high prevalence of child sexual violence, 22%. And of that, 31% of them are under 10 years old. And another very sad news is that 89% of the perpetrators of this sexual violence were known people. That is the saddest part. In view of such appalling level of prevalence of sexual violence among children, and in Nepal, with more than 90% of children enrolled in school, and our recent census told us that 2/5 of the national population under the age of 19. The study is focused, we focus this study on school adolescents, because school adolescents provide a largest and strategic platform for prevention of these twin human rights violations in our communities today and tomorrow. Thus, the objective of this study was to measure changes among school adolescents in their knowledge, attitude, and skills to prevent the twin problems of gender discrimination and sexual harassment before and after the intervention. This was a quasi-experimental study involving a total of 3,661 male and female students from 52 community schools across the nation. Of the total, 1,880 students from 26 community schools participated as the intervention group. They were empowered with the tips, experiential learning intervention for 24 hours, while 1,781 students from the other 26 schools enrolled as the control group with no intervention, but their knowledge, attitude, and skills were measured before and after the intervention. So, what was the TIPS intervention? We had developed an integrated experiential learning tool consisting of 3 modules. One was gender discrimination and sexual harassment, and you can see that. And the other was mindfulness of breathing, because gender discrimination, sexual violence also relates to mental health, as I showed you from the data also. And the self-defense technique, we took the help of Fight Back Nepal for learning self-defense skill. The results, pre-post test comparison was done using percentage point difference on key indicators. We also performed analysis of covariants to measure the changes in composite indices related to knowledge, attitude, and skills on gender discrimination and sexual harassment among both the control and intervention group. And the changes were found statistically significant with a medium to large size effect across all domains at 0.05 significance level. Now let me take you these 6 domains. The increment, statistical increment we found by doing the ANCOBA test. Now the first domain, proportion of students who understand about gender and sex. As you see that the blue is the pre-test and intervention and control on the left and right, pre-test and post-test. As you see that has significantly increased among the intervention after the post-test. Similarly, proportion of students able to identify sexual harassment, because many people didn't know what is sexual harassment. Many students didn't realize what is good touch, what is bad touch. So as you see that this domain also, we have seen that almost 60% increment in intervention group after post-test. The third domain, proportion of students confident to apply self-defense technique. As you see the blue line after the intervention post-test, way up, going almost 85% increment, and the control group 4.2%. Similarly, proportion of students aware of legal provisions and reporting against sexual harassment. This also has increased immensely among the intervention group compared to the control. The fifth domain, proportion of students having positive attitudes towards prevention of sexual harassment. This increment, as you see in the post-test intervention group, 82%. And there is a negligible increase in the 2.3% in the control. And the last domain, as you see, the proportion of students aware of mindfulness of breathing. The
Ma'am, you
technique,
have
the
only 2
anapana.
minutes to
Yes,
wrap up.
I'm almost finished. Thank you. So this has also increased. In the conclusion, the study result shows statistically significant increment. I'll hurry up now. The second bullet, these findings strongly suggest that empowering school adolescents can be an effective and sustainable strategy for protecting our children from gender discrimination and sexual harassment. As our previous speaker was talking about translating knowledge into action, as I remember, I pointedly, said by von Goethe, knowing is not enough, we must apply. Willing is not enough, we must act. So I hope in the spirit of today's theme, Swasthya ka lagi anusandhan, this evidence-based knowledge would fit in policy actions of health and other education sectors. Lastly, before I say thank you, I must offer all the people who have helped in this study our gratitude, and especially the mayors in the local schools and the teachers, students, and also I am grateful to Nick Simon Foundation for continued support for this, And lastly, I thank NHRC for giving us this August forum to present this study. Thank you so much.
Thank you so much, ma'am, for your presentation. You completed in time. So without any delay, let's move to another presenter. She's Kirti Lamichane, and she's going to talk on eye mapping of abortion stigma among girls and women of reproductive age in Nepal.
Hello, good evening, everyone. Thank you for staying this late, and thank you, chairs. Today I'd like to talk about our study, Mapping of Abortion Stigma Among Girls and Women of Reproductive Age in Nepal. That is women in the age group of 15 to 49 years. This is the list of authors' name and co-authors. Thank you, team. In 2002, abortion was legalized in Nepal. Perception about abortion are mixed in different segments of the population. Abortion services are widely available and used in the nation as a result of legislation. But still, the quality of procedures is unclear outside of medical facilities where nearly half of the abortions still take place. One of the major factors contributing to unsafe abortion is the abortion stigma. We've mapped the possible consequences of abortion stigma in this frame. So in presence of an abortion stigma, there is denial, shame, guilt, and a need of secrecy, which leads to delays in health service, exposure to untrained providers and unlisted health facilities, more unsafe abortion, and even a chance of self-induction, which might result in abuse, poor quality of health services, complication due to unsafe abortion, suicide, and even death. The objective of our study is to gauge the level of abortion stigma among WRA in Nepal and to explore the association between different social demographic characteristics of WRA and abortion stigmatization. For this research, we used quantitative research approach and descriptive cross-sectional study. In this map of Nepal, the orange color areas are our study site. So as shown earlier, we chose 2 districts, each from 7 provinces. The district having the highest and second highest abortion case proportion were selected. Geographical distribution was also considered during the selection process. Additional 2 districts, Kathmandu and Lalitpur from Kathmandu Valley, were also selected to capture data from the federal level. From each of the 16 selected districts, 2 municipalities, 1 urban and 1 rural, were chosen based on the number of WRA population in that municipality. Two wards each from 30 selected municipality were taken as the cluster. So there were total 60 clusters at the end. So at the initial phase, we decided to take 2,100 households as our sample, that is 35 households from each clusters to make it nationally representative. At the end, 2,286 WRA were interviewed. For data collection, after the approval from NHRC, both written and verbal consent and assent was taken, as there were participants from age group who were under 18. All researchers were trained on the study's research methods and tools. The finalized survey tool was pre-tested and uploaded in the Kobo Collect server for data collection. We used stigmatizing attitude, beliefs, and action scale as a tool to be administered for WRA. As you're gonna come across this SABAS multiple times in this presentation, let me brief you about SABAS. The SABAS is a validated tool used to measure stigmatizing attitudes and beliefs about abortion and its recipients. It includes total 18 items, which is further distributed in 3 subscales, with 8 items in negative stereotypes, 7 items in discrimination and exclusion, and 3 items in fear of contagion. SABAS is an easy summative scoring of Likert scale responses with a total scale of 5 each. Higher score means more stigmatizing attitudes, beliefs, and actions. For data analysis, sample weight was used before the analysis. Independent t-tests were used for bivariate analysis. Significance was determined at p-value less than 0.05. So let's move on forward to our findings. Our socio-demographic characteristics shows that the majority of our participants were from the age group 25 to 29 years, and the least were from 15 to 19 years. Talking about education of our participants, the majority of the participants had secondary education, and there were 140 participants who have never attended school. 83.4% participants were currently married, and 55% were living in urban area and 45% in rural. The left side of the left graph shows the provincial distribution of our participants, whereas the right one shows the wealth quintile distribution. Talking about overall stigma, as discussed below, SABAS scale has 18 items in total with 5 Likert scale measurement, making it the total of 90. Out of 90, the mean abortion stigma of Nepal was measured to be 46.53. Using similar tool, the study on abortion stigma were done in other countries, and the result of other countries were Ghana 47, Zambia 51, Kenya 54, Uganda 59. It seems Nepal has lower stigma compared to them, but we can say that abortion stigma still persists in our country. With this graph, we can say that abortion stigma is higher in higher age group. We can see the increment of abortion stigma with increase in the age group. The three subsets had this similar pattern, and the higher age group where abortion stigma was highly significant with higher age group. In this slide, we can see that with increase in educational level, there is decrease in abortion stigma. Unmarried women comparatively had less stigma, followed by currently married, and was the highest in the women who were divorced or separated. We can see in this slide that higher abortion stigma was there in lower wealth quintile population. there was not much difference in abortion stigma by residential setting. In this provincial level slide, we can see that Modest province and Karnali province have higher stigma level than compared to national stigma level.
2 minutes remaining.
Okay, thank you. Among the 18 beliefs, the most stigmatized beliefs were a woman who has an abortion is committing a sin. Once a woman has one abortion, she'll make it a habit. A woman who has had an abortion cannot be trusted. A woman who has an abortion brings shame to her family. The health of a woman who has an abortion is never as good as it was before the abortion. A woman who has had an abortion might encourage other women to get abortions. A woman who has an abortion is a bad mother. So with this study, we can conclude that abortion stigma is still prevalent in specific populations such as women and girls with low or no education and with poorest wealth status women and girls in Nepal. It is crucial to address the stigma associated with abortion and advance women's right to make decisions regarding their bodies. With this study, we would like to recommend that specific interventions are needed to reduce stigma in the community. And the stigma-related research on abortion and SRHRs should be prioritized to generate more evidence and to identify gaps. Thank you.
Okay, thank you, Kriti Lamichane. If you have any questions, queries, comments, please write it down. We'll take a few of them at the last of the session. So our next presenter is Javindra Bhandari. He is one of the consultant doing so many consultancy in policies and planning of HIV and other diseases in Nepal. His presentation is a scoping review of transforming HIV policy and strategies responses in Nepal.
Microphone ko chhema januस् sir.
Thank you very much. First of all, I would like to extend my sincere gratitude and to NHRC for giving this unique opportunity to present my sharing, and this is about the scoping review of transforming HIV policy and strategic responses in Nepal. Because of the time constraint, I do not want to highlight, go in details, but I would like to a little bit highlight the key points of it. My presentation outline is background, methodology, results, and conclusion. As we all know that HIV was detected in 1988 in Nepal. There are different modes of transmission, but heterosexual transmission is overwhelming, the dominant. And there is a transition from low-level epidemics to concentrated epidemic with rapid spread among key populations. To give you a very brief background, national policy is largely guided by HIV and STI policy 2011 and Nepal HIV Vision 2020, which is a kind of 2016 to 2021 strategic plan actually. And the new strategy also aims to end AIDS epidemic as a public health threat by 2030. The interesting thing is that how this HIV policy, the way we look at HIV, from disease to public health to development problem, because it constitutes social, cultural, gender, political, so many issues. The objective is to review historically how HIV policies and strategic responses are adopted by Government of Nepal, Ministry of Health, development partners, civil society organizations, and what does that mean to date, how it is transforming. I would like to mention that it is largely the scope review, but it also includes being part of the National HIV Strategic Plan 2016 to 2021 as a member, and as the national lead for developing 2021 to 2026 HIV strategic plan, being part of that processes. So we had a chance to, consult with a range of stakeholders from the government, senior officials from the government, Ministry of Health, beyond health sector also, like education, Ministry of Finance, local governance, and other partners, particularly UNAIDS, WHO, FHI 360, and other key partners who are supporting the government, and some sort of review on the relevant articles, grade literatures, and best practice guideline. I don't want to go in details, but I would like to show you a kind of historical progress, how the national response was, was transitioning or progressing. In 1988, it was the first National AIDS Prevention and Control Program. From 1990 to 1992, the first medium-term plan. And I don't want to go detail, but coming to the latest one is the 2016 to 2021, the National HIV Strategic Plan, which ended in 2021. And now we have National HIV/AIDS Strategic Plan, which is 2021 to 2026. So what are the key results or the key messages, the key findings? If we see from over the decades, we see that there is a gradual shift or departure from simply health policy response to wider multisectoral response targeted to key and vulnerable populations. And in our first plenary session also, the Health Policy 2019 and the new strategic plan upcoming, which is proposed, which also identified and prioritized the social determinants of health, but more prominently, the wider determinants of health. So the scope of health is not only the health only, but beyond health and the wider determinants of health, and it has also implication for disease-specific responses, and HIV is part of it. Rather than a generalized approach, scaling up of community-based differentiated services in the local context, like community and home-based care, community care center, and these are the initiatives how the policy from the conventional or the only service delivery model to the community-based HIV services or prevention, treatment, and care. Another aspect that the policy particularly highlights is the meaningful engagement of key and vulnerable populations, including people living with HIV. So there is a greater emphasis on that. And the prevention and treatment continuum using identify, reach, recommend, test, treat, and retain approach, which is also a kind of, people-centered approach, and the evidence-informed policy and programming. So these are the emerging, kind of guiding principles for policy and strategic actions. In the recent years, particularly from 2021 to 2026, and all the HIV policies, national HIV policies that are guided by global, HIV/AIDS strategy with the UNAIDS, produces and shares across the world. So there is a clear, emphasis on respect and promotion of social inclusion, human rights, and gender equality. So these are the areas where HIV response is also particularly focused on, and our new government, the National Health Policy, new strategic action plan for health, these are the areas where the overall health policy and strategies are also grounded, and HIV is also part. I also mentioned that there is a new adoption of innovative practices and interventions like HIV self-testing, community-led testing, index testing, PrEP, and initiation of community-led responses. Now the whole shift is, rest on the community-led responses, where there is a meaningful engagement of the people who are affected by HIV and their communities. I don't want to go this target, but there is an ambitious goal from 1990 to 95, 95, 95. So this is the scenario. About 30,000 are the estimated, HIV cases in Nepal, and the 90% becomes 25. यो 95, 95, 95 को यो प्रोग्रेस गरेको छ यसमा चाहिँ म डिटेलमा यो डेटामा गइनँ I would like to, because of the time constraint, I would like to go very specifically on the conclusion part. So I already mentioned that there is a whole paradigm shift on how HIV response is, articulated. So the end inequalities and AIDS, this is the whole, the essence of Global AIDS Strategy 2021 and 2026, so which places people living with HIV and communities at risk at the center of the response, so people-centered. Another paradigm shift is the response, the strategy and the policy is, transforming from service delivery, not only from service delivery, but the community-led response, not only from awareness, but from awareness to treatment, care, and support. And I already mentioned the key populations. These are particularly the sex workers, MSM transgender people, people who inject drugs, prisoners. And there is a clear focus on the young key populations because of the risk and the vulnerability. And I already mentioned that the clear emphasis is on right-based approach and the social inclusion, because there is diversity and there are, the critical needs for reaching the unreached population, there is social exclusion and all these things. And the new health policy and this HIV policy and strategic response are trying to, promote the diversity and equity. The last but not least is the clear focus on resilient community and health systems, community system to create demands in the community, to reach out those stakeholders, the key populations, and another is the health systems part. Again, I would like to highlight that the policy and strategies are, gradually transforming from medical, clinical to epidemiology and prevention science to social and behavioral science.
You should stop your time's up. Sorry about that.
This is coming in. And mainstreaming HIV into development and confronting inequalities is a key challenge in order to improve the coverage and to reach out the population at the center. I would like to acknowledge National Center for AIDS and STD Control, Ministry of Health and Population, UNAIDS, WHO, the Global Fund, Save the Children International, PEPFAR, EPIC, and all stakeholders who were part of this review and development process.
Thank you, Ravinderji. I think we'll
much.
go to the next speaker. Okay, thank you very much.
Thank you, sir. Sorry for a little bit of time extension. Thank you.
Our next speaker is Raba Thapa, and she's presenting assessment of skin carotenoid among school children in hill region of Nepal. Raba Thapa.
Good evening, respected chairs, presenters, and all participants. I would like to thank NHRC for providing me this opportunity to present the paper on assessment of skin carotenoids among school children in hill region of Nepal, and my co-investigators, Professor Dr. Sandukrit and Professor Paul Bernstein. We have no financial to disclose, and my outline of presentation will be as per the guideline of presentation on brief background, methods, results, conclusion, and recommendation. Carotenoids, as we know, is also known as pro-vitamin A, is the major source of vitamin A. Green leafy vegetables and fruits are the major source of vitamin A, and as a part of carotenoids, low level of carotenoids could lead to vitamin A deficiency, especially among the high-risk peoples like children and pregnant women. Vitamin A deficiency is a public health problem, especially in the low middle income countries, and vitamin A deficiency is a leading cause of various morbidities, especially the respiratory tract infections, gastrointestinal tract infections, and morbidity in the high-risk people, and also a cause of xerophthalmia, which is an irreversible loss of vision if treated lately. And as per WHO, almost 44 to 50% of the preschool children suffer from severe vitamin A deficiency. So vitamin A deficiency could be assessed using serum retinol, but the test is very costly and it is not available easily, whereas the carotenoids could be assessed easily with the use of non-invasive devices as a skin carotenoid measurement, and Vesimeter is one of the portable devices that we can use to assess the skin
Excuse me,
carotenoids.
can you keep the voice down? There is noise in the background. Please go ahead.
A single reflection measures takes only 10 seconds. It indirectly measures the serum retinol as a vitamin A level, as the previous studies from Nepal and other parts of the world have shown the very good correlation of the skin carotenoid with the serum carotenoids, and also the skin carotenoid with the serum retinol. The study conducted earlier in our country at the age 8 to 12 years of age showed very high level of low skin carotenoid in the hill region as compared to Tarai and mountain. And also there are no literatures from Nepal about the skin carotenoid among small children who are a very high risk of vitamin A deficiency. So this study aimed to assess the skin carotenoid score among children at the age 3 to 7 years of age in the hill region. So general objective is to assess the skin carotenoid among school children at the age 3 to 7 years of age, with the specific objective of finding skin carotenoid at various age groups to assess the factors associated with low skin carotenoid, and also to find the ocular problems associated with vitamin A deficiency and their association with skin carotenoid. This study was a cross-sectional study, and study was done in hill part as Nuwakot as a representative district. Based on the previous 49% prevalence of low skin carotenoid at the hill region with 10% non-response, the sample size calculated was 324, and study participants were 3 to 7 years of age, and 6 schools were randomly selected in Nuwakot districts, and equal number of children were taken from each school. So the inclusion criteria was the school children at the age 3 to 7 years of age, and exclusion criteria was those parents or local authorized guardian denied to provide the written informed consent, and children having scars or staining in all fingers. So detailed demographics, dietary history, and systemic and ocular complaints were recorded, and skin carotenoid was assessed using Vesimeter. It's a portable device developed in Longevity Link Corporation, United States. Is a commercial equipment used for the assessment of skin carotenoid, and 3 average readings were taken, and skin carotenoid level less than 150 reflection score was taken as a deficient in carotenoids and possibly vitamin A, as per the previous studies done in Nepal and elsewhere. The skin carotenoid score having less than 150, or those children having night blindness, underwent detailed ophthalmic evaluation with the anterior segment and posterior segment with dilated evaluation. Ethical approval was taken from the Nepal Health Research Council, and SPSS 20 was used for the statistical analysis. Chi-square or Fisher-Exact test were used for categorical data analysis, whereas the independent t-test and Mann-Whitney U-test was used for continuous variables. The significant variables found in bivariate analysis were taken for binary logistic regression to quantify the results, and p-value less than 0.05 was considered as statistically significant in this study. So these are the pictures from study participants from 6 different schools. And this is how we have examined the skin carotenoid using Bezimeter. We can see study participants at the age 3 to 7 years of age, and all the school headmasters were very helpful for selecting these children with a random sampling. And these are some of the children with refreshment with fruits. And all the participants, as mentioned earlier, underwent ophthalmic evaluation, those having reflection score of skin carotenoid less than 150. In the results, a total of 324 study participants from five public high schools and one private school was taken. The mean age of children was 5 years with the standard deviation of 1.3 years. Males were slightly higher, comprising of 53%, and 4% of the children gave history of pure vegetarian. This table shows the age and gender distribution among the various study participants. We can see that the distribution was quite uniform among the males and females, whereas the males were comprised of 53% among the total study participants. This table shows the frequency of vegetable consumption per week among males and females. We can see that 30% of the children said they use only less than they consume vegetables less than 2 times in a week, and majority, 66% mentioned like they consume 2 to 5 times in a week. So this shows the ocular complaints. 1.8% of the overall children had some kind of ocular complaint with blurring of vision as the most common symptom, and 0.6% of the children had some systemic complaint with cough and itching. So basically these were the healthy children. This figure shows the overall prevalence of skin carotenoid. We can see that almost 47% of the children had low skin carotenoid and 23% having borderline, that is 150 to 200 reflection score. And this table shows the skin carotenoid score among males and females. We can see that among those having less than 150 reflection score of skin carotenoid, males, it was more in the males. This figure shows that the skin carotenoid among different school children, that ranges from 74% to 9%. And this shows that among the more than 68% of the children having low skin carotenoid were from below 5 years of age. And we conducted bivariate analysis, which showed that age was the significant association, and also the low BMI, and in multivariate analysis, age was significantly associated 2 times higher risk of having low skin carotenoid among those having less than 5 years of age. And we find no patient having history of night blindness and history of other ocular symptoms of xerophthalmia. So limitation is only one district was taken in this study, and to conclude, almost half of the school children had low skin carotenoid, and low skin carotenoid was significantly associated with lower age group. So dietary awareness program need to be enhanced, and vitamin D supplementation need to be continued in this small age group. So to recommend, awareness campaigns are very necessary, and continuity of vitamin A program is very needful as it is continued now, and further studies are recommended. So my acknowledgement goes to Thresher Research Fund and Muran Eye Center and Tilonga Institute of Ophthalmology, Education Coordination Unit, and various schools involved in this study. Thank you.
Thank you, Rabathaba. The questions will be at the end, so you can go back to your seat. Next speaker is Usha Ghimire. The topic is opportunities and challenges in the adoption of a nationally supported digital system for scale-up of community health support program in Nepal.
Thank you, Cheers. Good evening, everyone. I'm Usha Ghimire, Program Lead from Department of Community Program, Dhulikhel Hospital, Kathmandu University Hospital. I believe that Nepal is a fertile land for digital health innovation and experimentation. On listing the digital health power in the rural Nepal, today I am going to present about opportunities and challenges in the adoption of a nationally supported digital system for scale-up of community health support program in Nepal. Talking about community health support program, The community health support program is implemented in Dolakha district by Dhulikhel Hospital, Kathmandu University Hospital with technical support from Possible, with an aim to provide a continuum of cure to the beneficiaries in the community to create a healthy community and healthy people with support in achieving universal health coverage. It uses the community health workers model as per World Health Organization recommendations. Now talking about who are community health workers, they are trusted local members who are trained, regularly supported, monitored, who work full-time, who are salaried, and whose minimum education qualification is 10th standard. Now, what do? They mostly provide the program intervention or the reproductive, maternal, and child health, including the non-communicable disease, and they emphasize on different components of reproductive, maternal, child health like antenatal care, postnatal care, under-2, nutrition, and family planning, and they bridge health facility and community. And they are the ones who take health services at the doorsteps of the rural community. And they provide need-based longitudinal care, make door-to-door health services on major program interventions like screening, counseling, referral, and follow-up. And they also help in local health system strengthening by supporting the local health activities. So how do? Is they use a mobile-based platform that is integrated with a questionnaire of the logic flow, which helps them in decision support to help them in screening, identifying high risk, referrals, follow-up, and data used to improve the program. And they also work in coordination with the female community health volunteers in the community area. So our program follow the pathway to cure of the continuum of cure approach, which firstly defines with household, family, and individual enrollment, target population registration, surveillance of the target population, counseling, referral, and follow-up. The program data and figures till 2022 is the total household enrolled are 33,075. Total family enrolled is 32,533. Total population enrolled is 100,033, 588, and the total number of community health workers are 44, and we have the catchment area of 1 lakh population in Dolakha district, which covers more than half of the population of the Dolakha district. So talking about what were the objectives of the adoption of a nationally supported digital system for the scale up of community health support program in Nepal. So first was to align with government of Nepal's policy, which specifies that a national guideline on community health program mainly mentions about professionalized community health cadre, which should be supported by health technology that integrates with the national community health information system. Similarly, national digital health policy also emphasized on scalable, acceptable, user-friendly, open source, and free platform. And also, second objective was to ensure the sustainability of the community health support program. As the platform is open source and it has an active global community and contributors, and it has a phenomenal local implementer program team available, so it ensures the sustainability of the community health program. Similarly, third objective was to shift to the user-friendly digital platform, as the mechanism for the communication, update, change request is very fast, and it has high interoperability with existing national digital health platform, including district health information system. And also it has added features such as task generation for the automation of follow-up, team collaboration using internal messaging features, and flexibility of utilization for monitoring and evaluation, which is very pivotal in the case of program, especially in the rural setting. So regarding the implementation preparation, we had different kinds of cadre in the program during our journey. So we had lots of different cadres like health IT professional, program team, local grassroots implementers. So we had a lot of cross learnings regarding the architecture of the program, expectation, limitation. We had lots of alignments, and we have a lot of the program's proactive strategy and program strategy that made a win-win situation later. So talking about the methodology, regarding the implementation steps, firstly, the team engagement, capacity building, consensus-based data migration, multi-level quality assurance, observation, discussion notes, and desk review was done for identifying the opportunities and challenges. So regarding the implementation phase, there was a lot of development of repositories of learning material in order to support the implementation in a smoother way. So training of trainer was robustly provided to the community health support program in order to incapacitate them to use new platform, and involvement of community health support program team in the quality assurance was done, and Mainly, the training of the community health worker was done in the multiple slot in order to make them abreast about the new changes in the platform. And also the workflow verification was done by community health workers, community health nurses, community health officers, robustly in order to maintain the quality of the application. So regarding the post-implementation phase, the smooth operation was facilitated by checking the quality of data, monitoring and evaluation with respect to acceptance, troubleshooting issues, checking with the program team, and sharing the experiences with the global and local community. Regarding challenges and opportunities, it was not an easy journey. We had a lot of language barrier, a lot of communication problems, though we overcome it and made a grand historical application and platform change. So the major opportunities in adopting the system was cross-learning between the health IT professional and the grassroots implementers on the digital platform. As we had a different language, so we need a lot of cross-learning in order to understand the program from the IT perspective and from about the IT languages from the program perspective, and we had also challenges of explaining it to the local implementers. So next opportunity is the synchronization of the terminologies used by implementers and health IT professionals. And third one is, as the program team was highly experienced, so the transition was smoothened. And similarly, prior experience of our technical team has a prior experience of working in an open source ecosystem, which helped in building a better product and ensure the quality of the product. So further talking about the opportunities, there was gradual and continuous introduction and training for the community health workers, because they are the one taking the platform and connecting to every households of the rural community. So they were abreasted about add-on features and limitation of the new product. So similarly, from our side, we also mainly focused on reducing huge deviation in the design and align closely with both the platforms and help CSW to navigate the new platform easily and tailor any deviation clearly to them. So, and the frequent trainings and feedbacks were taken through entire team. So the major challenges were the resistance to change of the architectural design, the gap in the communication, as I mentioned before, because we have different language, IT language and programmatic language. And similarly, as I mentioned before, that we are situated in the rural setting, so interrupted communication and frequently disrupting technical facilities were one of them. So some of the recommendations are, since digital health is a missing dot in order to strengthen the local health system. So if we be strengthened digitally, then our local health system will be also strengthened automatically. I believe in that. And so there should be selected platform in the rural setting and in any of the setting that should be open source and that should align with national digital health policy and data standards. So we should build resources more on health technologies, incorporate population health informatics in academia, build local health IT community in collaboration with academic institution. So my special acknowledgements to Nyaya Health Nepal, municipal offices from Dolakha, community health workers, community health nurses, Department of Public Health, and all the team from SUNY Ek and Possible. So thank you, team, for making this implementation process smoothen. And lastly, I would just like to say that it's high time on rethinking about digital health policies that can connect to the rural community and get with the motto of universal health coverage and get with the motto of reaching the unreached through the digital platform in Nepal. So let's rethink on making digitally enabled Nepal. Thank you.
Thank you so much, Ushaji. So our next speaker is Kritika Dikshit. She is going to talk on stigma, depression, and quality of life of people undergoing tuberculosis treatment in Nepal along longitudinal prospective cohort study.
Thank you, Chairs, and thank you all the participants for staying up quite late. I truly appreciate your presence here. Namaste, I'm Kritika Dikshit. I'm the research manager at Virat Nepal Medical Trust and a current PhD student. So today, my research is about the psychosocial consequences of tuberculosis in Nepal, and we mainly assessed stigma, depression, and quality of life among people who are living with TB in Nepal. So 150 years from ago, Rodolphe Virchow, a very famous scientist, recognized TB as a social disease. And this is mainly because TB has its roots with its poverty, undernutrition, crowded settlement, and poor hygiene. But even today, TB is a major epidemic. Every year, around 1.6 million deaths occur because of this preventable disease. And we want to end this epidemic. But to do so, we are unable to achieve this target of the Sustainable Development Goals by 2030. And one of the key barriers to achieve this target is the TB stigma and psychosocial impact that is prevalent today. And TB is, again, a major public health problem in Nepal. Every year, around 70,000 people, they develop this disease, and around 17,000 deaths occur every year. And this is because the focus of the TB program globally or in Nepal has been largely biomedical, meaning that we are focusing mostly on the pills, the medicines, and the basic diagnosis for TB. Again, in Nepal, the standard TB treatment for a drug-sensitive or a simple TB is 6 months of duration. And the first 2 months is called as intensive phase, and this, until the last month is called as continuation phase, which I will come later on. So in 2020, we conducted a study, qualitative study, where we tried to understand the barriers regarding accessing the TB treatment in Nepal. And one of the common barriers we identified is the stigma and discrimination that is prevalent in the society. Many people still regard TB as punarjanmako pap, or even they are isolated at one place. And many people, they have guilt about having TB. Many people also reported to have anxiety and depression. And we wanted to understand this qualitative data in the figures or in the numbers. And again, a very known fact that as TB has a psychosocial consequences globally, it's universal. But we were also interested to understand this figure and what are the local experiences in Nepal. Therefore, we analyzed the psychosocial consequences and mainly looked into stigma, depression, and quality of life. And again, the evidence is quite limited in the context of Nepal. So in this study, we assessed the 3 outcomes, and we studied this at intensive and continuation phase. So intensive, again, I would like to repeat, it's again, 2 to 3 months of the TB treatment, and the continuation phase is around 5 to 6 months of the treatment. This study was conducted in 4 sites: Chitwan, Makwanpur, Dhanusha, and Mahatari. These are the sites where TB is high prevalent, and there is also high poverty. So briefly about the methods. This is a prospective cohort study. We recruited around 221 adults with drug-sensitive TB. We interviewed the participants at intensive phase, which we also call as a baseline of the study, and the continuation phase, which is called as a follow-up in the study. We collected the data for stigma, depression, and quality of life. I will be talking about the measurement in my next slide. And because this is a descriptive study, we performed descriptive analysis using Stata version 15. So to measure the stigma, we used Van Rhee stigma scale, where we measured the characteristics of stigma. It has 10 items, and we measured in percentage. For depression, we used the Patient Health Questionnaire, commonly known as PHQ-9, and we measured the score, the higher score representing the high severity of probable depression. For quality of life, participants were asked to rate their health condition for that day, and the score ranged from 0 to 100, 0 meaning the poor health and 100 meaning the best of their health. Again, we also measured using the Euro Quality of Life Index, which scored from 0 to 1. To conduct the study, we received ethical approval from NHRC and written informed consent from all the participants. So now I would like to go into the results. In the results, 67% of the participants were male, which is in line with the National TB Program data, where around 70% of people diagnosed with TB in Nepal are male. The mean age was 48 years. 54% did not have any formal education. 67% were unemployed. So about this stigma scale. So as I mentioned, there are 10 items in the Van Ries stigma scale. And here you see this radar diagram, which shows the blue color shows the baseline, and the orange color shows the follow-up. So here we can see that the participants towards the follow-up reported slight decrease in all the items of the Van Ries scale, meaning there was slight reduction in the stigma reported by the people. Now, if we look at this data more closely, we see that around 50% of the participants reported that they fear telling about having TB outside their family members or outside their household. And they also reported having guilt of having TB. And around 40% reported that other people who do not have TB, they maintain a distance from those having TB. They felt uncomfortable when they were close, or they also feared for those having TB. So the important findings from this stigma was that stigma persisted throughout the TB treatment, and this is what we wanted to understand in this study. Now, what about depression? So in the study, we found that around 30% of the participants reported having some form of depression from mild to severe level. And looking at this data in a more different angle, the red color here shows the severe level of depression, and blue color shows the mild depression. So the first bar, which is a baseline period, and the second bar on the right figure is a follow-up period. So in the follow-up, we found that the participants, they have slight reduction in the severe depression, meaning they reported having less severe depression. However, the overall level of depression was quite persistent throughout the TB treatment. So depression was also very persistent throughout the TB treatment. Now, quality of life, when we asked the participants to rate their health condition for that day, we also found that in the follow-up period, the participants increased their self-health rating. Similarly, when we used the 5 indicators to understand the quality of life, mobility, self-care, daily life activities, pain, and anxiety, around 30% of the participants reported to have pain or discomfort or anxiety or depression in the baseline, and it was reduced by 50% during the follow-up. And the EuroQual index for the quality of life, we again found the follow-up, in the follow-up, the participants tend to report that they have higher quality of life. So to conclude, in the study, we found that the stigma was quite prevalent, and stigma especially related to having guilt of having TB or non-household disclosure was quite prevalent, and so is the depression. Therefore, if we want to end the TB epidemic and achieve the target of Sustainable Development Goal, we want to have accelerated efforts to reduce the consequences of having TB. And therefore, there is a need of locally appropriate psychosocial interventions to decrease stigma and increase mental health as well as quality of life. So I would like to acknowledge with thanks to all the participants who were involved in the study, the Impact TB BNMT staff team, the National TB Program, the National TB Control Center, the funders, RSTMH, Farrar Foundation, and Wellcome Trust for their support in the study. Thank you.
Thank you so much. Let's go to another speaker, Sulata Karki. She's going to talk on the implementation realities of digital antenatal care improvements intervention in Nepal, auxiliary nurse, midwives as street level bureaucrats.
And namaste. I am Sulata Karki. Today I am presenting on the title, The Implementation Reality of Digital Antenatal Care Improvement Intervention in Nepal, Auxiliary Nurse Midwife as a Street Level Bureaucrat. Quickly walking through the background, Nepal has seen significant improvements in maternal health service coverage with growing attention to ensuring high quality care. So this study is a part of a process evaluation of mobile health integrated rural antenatal care project that aim to improve the quality of antenatal care using electronic decision support system, that is EDSS, in primary healthcare settings of Nepal. So why process evaluation? To really understand the contextual factors, reason behind the success and failure of the intervention, and challenges faced by the healthcare provider during the implementation. So the main objective of this study is to understand the antenatal care context and explore how auxiliary nurse midwives responded to the EDSS implementation in primary healthcare facilities of Nepal. So this was a longitudinal qualitative case study conducted in 4 facilities as a part of a process evaluation. Data were collected at multiple time points between December 2021 to January 2023. It involved repeat ethnographic observations, informal conversations, and formal interview with the ANMs. We also conducted a validation workshop for participants to respond to and reflect on findings. Field notes and transcripts were analyzed thematically using DDoS software. So before moving towards the process evaluation result, I want to highlight the headline results of the overall study, that is the MIRA study, because I want to link these findings with the process evaluation results. Generally, the EDSS implementation was not as successful as we hoped to improve the quality of care in primary healthcare facilities of Nepal. So in-depth process evaluation really helped us to explain why. So we really get a good insights from our in-depth work on antenatal care context understanding. How our EDSS was designed to provide antenatal care was a bit conflicting with what they used to provide antenatal care. In a way, how they used to provide the care, because there are so many points here. Over here, I want to highlight key points. In usual settings, 2 to 3 ANMs work together to provide antenatal care, but our EDSS was designed to provide one-to-one care consultation to the client. History taking was often guided by the ANC card in these settings, but our EDSS recommended to obtain all the histories as recommended by the guidelines. Similarly, antenatal care package, that is laboratory investigation, was done once during the entire pregnancy, but this EDSS demanded to perform all the routine tests in all protocol visits, that is, for example, urine protein test in all routine visits, but the practice is they usually perform once. They also make a sensible judgment to provide counseling and care to the woman based upon their symptoms reported, but EDSS demanded to provide equal care to all women in all visits and also to provide counseling in all routine protocol visits. So the headline findings from this slide is like how our EDSS was designed to provide antenatal care was a bit different than what was practiced in the usual settings. So incorporating EDSS into this into their workflow was a bit conflicting and challenges to ANMs. So moving towards how ANM responded to the EDSS implementation, here I just want to highlight more about the findings from interview versus in-depth observations. So generally in interview, they like the idea of EDSS. Almost all express the positive aspects of the EDSS application with few technical problems they reported. But what we found in our observations was like some untrained ANMs never showed their interest in practice. They felt burdened and pressurized to use the EDSS. They also well explained the function of pop-ups and utilization of pop-ups in practice. But what we have observed in our longitudinal observations was they utilized this EDSS as a more sort of record-keeping application than that of decision support system. So again, I want to highlight here like how valuable was in-depth observation to explore the ground reality of utilization of EDSS in practice. Here are some of the examples from the verbatims and field notes. For example, one A&M mentioned many points are being missed when we do without using tablets. When we use the tablets, it reminds us, and if there is any problem, the tablet suggests advice. Like if the blood sugar is high, it suggests what to do further. And if there is a minor disorder like nausea, it suggested the statement about food. That is useful for us. So some express the technical problems also while utilizing the EDSS. They also mentioned like the whole workload will increase, but EDSS is our regular work, so it will be continued as regular work in future. This was the case of formal interviews, but what we observed in our observations were a bit different, and it was conflicting as well. Like they utilized the EDSS as a sort of record keeping. They didn't utilize more often the prompts and recommendations suggested by EDSS, and they shortly navigate this EDSS and completed within a minute. Sometimes we have heard of informal conversation among the A&M saying like, whenever I have a mood, I use this EDSS for entry. And we could hardly observe the few observations where EDSS was properly utilized as recommended as per the guideline. But in the majority of the observation, we found A&M clicking the photographs of ANC card and inputting the informations. Some of the mandatory fields were inputting the normal measurements, and counseling were often marked as marked on without providing the information. So this one is the process evaluation results, why EDSS was not utilized as it was meant to be. So there were many factors behind this. I want to highlight the key factors and key points over here. The organization factors. In some facility, there were used to have one specific ANC day, so A&M felt time pressure to utilize the EDSS as it was meant to be, because we have also observed like 35 ANC clients in a day, so it was like impossible to utilize the EDSS as a sort of a decision support system. Similarly, the individual factors, the motivation and need of a formal training, geographical factors, the transportation issues in the rural area, socio-political factors, like they were more, they don't want to try, they don't take the risks in this facility because they fear of having violent behavior from the client perspective. There were some challenges from the client part also, for example, financial problems, household problems. So the client also doesn't want to have more consultation with A&M. They want a quick consultation because these are some of the factors that hinder the successful implementation of EDSS. Similarly, the major factor we found was the perceived belief and attitude, where they felt like they are already providing good quality of care in their settings at their level, and they also view themselves as seeing the healthy pregnancy only, so they don't want to take risks, and they immediately refer to the medical officer who is present in the facility or to the higher center. So these are the factors we found through this process evaluation and in-depth observations. So finally, to conclude, longitudinal qualitative case study contributed to unpacking the implementation reality. For successful intervention, in-depth evaluation will be really valuable to understand not just whether it works or not, but also why. And to improve the quality of care and enhance the performance of healthcare providers, we need to understand the context and ground reality to fit our intervention into the practice. I really want to acknowledge ANC clients, ANC staff, facility in charge, local municipalities, research assistants, and entire MIRA project team, and my co-author Seema Das, who is present over here, and Dr. Biraj, Dr. Awa, and my one and only mentor and supervisor, all the way from London School of Hygiene and Tropical Medicine, Lobde Penkakana, who really help us to contribute into this project, and Medical Research Council, United Kingdom. Thank you so much. Thank you for listening me.
Thank you for finishing on time. So our competitive session is over. Now we have 3 invited talks left. Next speaker is Abriti Arjal. And Abriti is going to talk about community engagement to tackle antimicrobial resistance, opportunities and challenges.
Thank you, chairs. Because of time limitation, I would directly like to go to the presentation. So today I will be sharing some of our experiences that we have gained over the years using community engagement approaches, particularly to tackle antimicrobial resistance. So why community engagement and why for antimicrobial resistance? So we all know that antimicrobial resistance is a global threat and is also considered as a One Health problem and is underpinned by complex drivers and behaviors where social and some of the systemic factors further triggers the misuse. So so with this context, regardless of doing multiple system strengthening, if they are not used, if the antimicrobials are not used appropriately, antimicrobial resistance cannot be tackled. And thus, we have been knowing and we have been listening that public awareness is important for this cause. But then now it's high time that we move beyond public awareness and engage and actively engage with individuals and communities to actually identify the real needs, the real barriers, and then come up with the community-led solutions that actually helps tackling antimicrobial resistance at the community level, at the system level, and at the organizational level. So we at HERD has been engaging with multiple level of stakeholders at federal, provincial, and local level to tackle antimicrobial resistance and community engagement, particularly where we try to co-create the solutions together with the community. Its implementation and evaluation has been one of our core engagement areas. So some of our projects that we have, where we have been using community engagement, I have kept them here, and they are like Karen, where we used community participatory video making as an approach, the CoStar project, where we used community dialogue approach as a method, and another one is more co-creating a AMR resource pack together with the students and teachers that would help actually understand the antimicrobial resistance issue and its solutions at the school for the young children. So what approach we really took and what really worked based on our experiences? I'll be talking some of them now. So during the entire process of community engagement throughout these studies, stakeholder engagement has been our utmost priority because we feel like if the stakeholders are not engaged from the beginning, the ownership is not there, and if the ownership is not there, the sustainability of the program or of the intervention is very limited. Therefore, we have been engaging with the stakeholders, identification of the stakeholders from a One Health perspective, and then sensitizing them throughout the process by engaging them in various meetings, and then discussions throughout the project period has been our approach that we have been adopting. So in one of our approach, that is participatory video making, what we started was with we engaged with the community members, where we actually conducted a series of workshops with them. We used various participatory activities with them to actually explore what they understand by antimicrobials, if they really understand antimicrobials or not, or what antimicrobial resistance are there, and what are the behaviors that actually they feel, or what are the factors at the community level that is leading to the antimicrobial resistance. So with that, the environment was created where they really shared their experiences and their understanding in a very comfortable and in a comfortable way. So based on the issues identified, they then decided on a solution, or let's say an output, or what would they want to do in order to create awareness or to tackle the antimicrobial resistance. So in this project specifically, the community people who were engaged in the workshop created and developed a film, like various films, short films, based on the understanding of the antimicrobials throughout the series of workshops, and based on what we discussed with them. So now when the films were developed, so they were community-led, and they then presented the film in front of the stakeholders, including the local stakeholders and the community people, where they took the whole ownership of the event. They invited the stakeholders like a mayor, they invited their community members, they led the entire program, and this made us realize that it's a community-owned solution. It's a community-owned output, and the ownership and the reflection also from both from the community and the acceptability from the community and the stakeholders were like wider than what we have been saying when these activities or these engagement were limited. And these outputs was not limited to just being showcased, but now these outputs are the community property, community owned, and these films have been used very much like often in various other programs. For instance, like in like in the commitment or the willingness from the mayor in one of the municipality, this video was showcased also to FCASVs, where they tried to show what are the issues and the solution and how it can be addressed. So in the another approach where we in the another approach of community dialogue approach, so we are trying to co-produce CDA, community dialogue approach materials and delivery mechanisms. So here what we are doing is like we have conducted formative study where we actually try to identify the contextual drivers, and the information from the findings, the information from the formative study has actually been used to inform the materials that will be used further by the community, or that will be further used in the CDA materials. So adaptation has been a rigorous process here to, so that the information that's there, that needs to go to the community is not something beyond the context, but then like is rather from what's there in the community level. So say, various workshops and discussions are done, and social mapping has been done to identify the issues and what are the key messages. And here, in order to embed this whole process into the system, we have been doing a series of cascaded training where the master training of trainers are developed, who are the stakeholders from the government entities and academic organization and research agencies, not only from health, but also from animal and the environment sector. So let's say, for example, the MTOT participants are the stakeholders from the federal level, then they go and train the stakeholders from the provincial and the local level, and now the local level stakeholders would train the facilitators who actually would implement the community dialogue approach at the community. And after all these series of training, the implementation will happen at the community level, which would go for like 8 sessions, and where the issues will be explored together with the community, and the actions will also be agreed and derived from the community people present in that community dialogue approach. So yes, as I already mentioned, so in another one of the project, we actually co-created the output, co-produced the output from, together with the school teachers and the students. So throughout this process, we followed the principles of the community engagement approach, where trust was very important between these stakeholders and the community people, equity and inclusiveness, like involving people from different sectors and then like different levels was important, and understanding and giving them power, authority was also important. So it's not a one-way learning process. So we as a research team learned, and then the community people and the participants also learned. So contextualization and co-creation. So underlying these principles, what we achieved, I mean, like what it led to is strengthened partnership with among community and stakeholders that actually increased ownership, and then like it resulted in a shared power and increased trust and sustained relationship. So the knowledge was developed and the local issues were identified, and the knowledge exchange was happening even beyond the project, because the community people were empowered, and then the local champions were developed through the process, and increased community capacity enabled the process of knowledge transfer. Similarly, the community-led solutions were developed, which improved, which then was more actionable, recognized, and better sustained. Yes, but there are challenges. So equitable partnership in such topic where the scientific accuracy can be challenging is something to be thought about. AMR is a kind of invisible problem, so it's not directly impacts people's life. So it's very difficult to make people understand like why this is important. And sometimes like co-producing is another challenge because of the skills and the skills available of the community members, and yes, the volunteer natures are limited additional incentive and evaluation challenge exist. So yes, these are the key lessons. Engagement is a continuous process, and understanding the stakeholders and community is important. Creating a platform for dialogue and sharing and acknowledging is very important. But last but not the least, contextualization and adaptation is very important. There are similarities, but then there are also wide variation and differences. So we should acknowledge that and move further with the community engagement approaches. So yes, thank you everyone. Thank you for your time and patience. Thank you.
Thank you, Abriti Arjel. She's a public health professional and she's associated with HERD International. Sorry, I didn't introduce in the beginning. Our next speaker, invited speaker, is Dr. Indra Bahadur Napit. He is a medical doctor who specializes in orthopedics and currently working at Anandavan Hospital. And he's going to, the title of the talk is Community Engagement in Research.
Sorry for technical problems. Good evening. I'm Dr. Indra Napit, orthopedic surgeon working at Anandavan Hospital and leading the research projects. I'm also a PhD student at the University of Warwick in UK. So we just heard about community engagement, and now I'm going to tell you what's the role of community engagement and involvement in research as a group of people as community. So community engagement and involvement in research is a process that incorporates input from people who the research outcomes will impact and involve such people or groups as equal partners throughout the research process. CEI incorporates involving people affected by a health condition and or their carers in the various stages of a research proposal. This may include planning, designing, implementing, managing, evaluating, and or disseminating their research. So I'm talking about NIHR vision of CEI because our RIGHT project, the research study going on at Anandavan Hospital, is funded by NIHR UK. So NIHR's community engagement and involvement vision is that all global health research is undertaken in collaboration with the communities who are most likely to be affected by the research outcomes. So community, the term, broad term community is used here to include patients, carers, policymakers, healthcare workers, community organizations, faith groups, service commissioners, and others who might be considered as key stakeholders. And there are three key terms used in this CEI. That's participation. People take part in a research study or clinical trial. Engagement means information about research is communicated and shared. So it's only sharing of the idea as engagement. But involvement as a main keyword, it means members of the public are actively involved in research projects and research organizations. So NHR has given significant emphasis to CEI as part of the UK government's commitment to the Leave No One Behind agenda, a central and transformative promise of the 2030 Agenda for Sustainable Development Goals. This commitment requires researchers and other stakeholders to consider issues of marginalization, discrimination, and inequality, and identify measures to address these challenges when undertaking research. So NHR expects communities to be actively engaged and involved at the stage of research when priorities are being decided. So that means before even you plan about the research, and when research is being designed and funded, so while writing the proposals and designing, and throughout the delivery of the research project, and in dissemination of research outputs. So as patients and the public work alongside researchers to shape what research is done, how research is carried out, and how results are shared and applied in practice. So the motto of NHR CEI is nothing about us without us. So we need the people, group of people as community to conduct the research. So on the RIGHT project in TLM Nepal, we are conducting 3 research projects, one clinical trial as tribal study, and then Sherpa study in community, and also sustainability study of the previous phase out projects. So TLM Nepal RIGHT project organized several CI meetings every 6 months in last 3 years with stakeholders, that is leprosy affected people, representing organizations including IDEA Nepal, READ Nepal, Lava Nepal, New Saddle, Shanti Seva, Kokna Arogya Ashram, along with government officials, experts from leprosy field, and NGOs working in the leprosy field. So we included them even from beginning of the proposal writing. So at Grant Development in 2018, we invited all these stakeholders at Anandman Hospital to discuss about the proposal. And then we implemented the project in 3 countries, in Nepal, India, and Nigeria. And during COVID pandemic, we had to conduct all these CI meetings online with the team from UK. So we conducted this in July 2020 as well. And also in December 2022, we also had representatives from NSRC. So Namita Madam was with us. And we had this CI meeting also out of Kathmandu. This one was in Lalgarh Hospital. And we had most of the stakeholders, leprosy affected people from different self-help groups in Province 2. So as I mentioned, this is implementing in Nigeria also. So these are CI meetings with stakeholders in Nigeria. So as a way forward, we would like to recommend that all research projects in Nepal incorporate CI to improve the relevance, making them accountable and taking ownership and sharing the final results with this group. So usually we might find that bit difficult or feel uneasy to share our final results with the stakeholders, but that's reality, so we have to do it. And we believe this will impact the uptake of research findings in policy and practice, improving the health and well-being of communities in Nepal. So these are our partners, NIHR, and our project is going on in partnership with University of Birmingham. And this is our team, so we'd like to acknowledge our team at Anandman Hospital, at Leprosy Mission Group, University of Birmingham, and NHR. And this is our team from all 3 countries and UK. Thank you very much.
Thank you, Dr. Indra Bahadur Napith, for such short and sweet presentation. Our next speaker and our final speaker of the session tonight is a guest speaker from India. Professor Dr. Sandeep Srivastava is an orthopedic surgeon with a PhD in medical education, MBA in global leadership. He is currently working as a mentor and chief scientific officer in Datta Meg Institute of Higher Education and Research, Wardha, India. Professor Srivastava has developed his own technique for treatment for complex wounds by autologous PRP, and Sandeep's technique for assisted regeneration of skin, stress therapy. He's actively involved in research with 152 international presentations, 76 publications. Dr. Srivastava was felicitated with India's Superhero 2022 award for services during COVID and Rashtriya Chikitsak Seva Samman 2022. Professor Srivastava.
Thank you so much for the kind words, respected Chair, Dr. Janak, Co-Chair, Dr. Amrit. At the outset itself, I thank profusely Dr. Pradeep and Dr. Prerak for inviting me over here, and the Nepal Health Research Council for such a wonderful summit. I thought that my talk would be the last and I would be showstopper, but perhaps I am standing between you and your dinner. But keep it apart. It's my pleasure. I bring greetings from my institution, the Tambagi Institute of Higher Education. For all of you who have never been to India, I come from Wardha. And if you are fond of playing dartboard, and if you miss the central India, you will hit me. And I am there to welcome you. So I bring greetings from my institution. And what I am going to talk about is like what I have been doing mostly for last almost more than 10 years. So like it's important, I heard all of you, it's important to translate the care in the community. But it is as well important to translate a care in the hospital, inside the hospitals. So friends, I share my experience to translate a care for a very complex problem. It's a prototype problem of dealing with wounds. We know that people do get wounded and they at times have very big wounds, which are very complex treatments and leading to a lot of financial burden as well as infirmities, including amputations. There are children who get wounded because of nerve injuries, the infections, very bad infections, and at times the bones, etc., get exposed and they are like almost losing their limbs. And at times they have almost nearly lost their limbs by gangrene setting up. What is happening is basically this vicious cycle of necrosis, tissue loss, and infection. The more I do surgery, the more I lose the tissue, and the more difficult my reconstruction becomes. So in 2009, with the emergence of regenerative medicine, we just started thinking, why not try it for some complex problem like this? And there are 3 regenerative medicine products we all know. Stem cells, which are cultured, MSCs, which are both can be cultured or centrifuge, and platelet-rich plasma, which is a very simple process of just centrifuging and using it. So like I wanted to develop a protocol which everybody can do it, not like a tertiary care center and a lab. So we focused on platelet-rich plasma. And like a typical things, I framed a set of questions how I will translate this care. So right from our understanding what is PRP to how to prepare it, what problems can be dealt, is it safe enough, what are the right doses, right way to give it, the frequency of giving it, the duration when I should be giving it, the mainstay therapy, can it be, and lastly, can I generate some IPRs, everybody loves money, and more importantly, will it be a groundbreaking research? So that was my aim of translating a simple thing. And in 2010, we started reviewing the whole literature, and it was simple. Yes, I can do it in my labs by just double spin centrifuge techniques, and I can use autologous blood, taking it from the patient itself, low volume, 20 ml, make a PRP of 2-3 ml in my centrifuge lab, and start using it. But it took us 1 year to understand this, and standardize what RPM spin machine works to give it a yield which is good enough. And then we started testing in 2010 on a rabbit model on tendon healing, typically on an animal model as we start with the preclinical studies. And then I started using it as an adjunct therapy. So this is a small girl, 3-year-old, who has suffered a humerus fracture and has lost her skin. So I used it by giving PRP and the skin healed. So I was like very enthusiastic, yes, it has a potential to heal. And the next 4 years I was working in different forms, using it as a gel, but because I wanted to work on a large area, so gel was not sufficient. So we need to invent something more than gel. So we started infiltrating first inside the wound, and whenever I inserted inside the wound, I lost all the PRPs. It just flew out of it. And then I thought again, like there has to be something more to it. So we started with another way where I started infiltrating on the skin. So PRP is a growth factors, and I hit the idea that if I regenerate the skin, that is the point I wanted. So I started trying to assess the skin regeneration. And with all the adjunct therapies, as IEC was not allowing me to do it till safety is established. And so that is how I did it. And then 2014, we finished almost like 100 cases. with standardizing dose. The main question was, when do I repeat it? So the literature was full of like 0 days, 4 days, 7 days, 21 days. Then I went again to books, studied the whole physiology which I had forgotten over last 2 decades. And then I hit that, see, this is a simple cycle. It's a pro-inflammation which has to take place. And this cycle, if you look at it, if I give it on 4th day, probably I will be able to sustain the inflammation. And that is what I need to regenerate. So I went back to the animal model, started doing the CRP, looking at the CRP levels of inflammation. And yes, I got a solution. It's just like I have to give it again on 4th day, every 4th day, till the wound heals. And then I started giving in orthopedic settings where the plants were exposed and all those things, and it started working. We presented globally our studies. And then I developed a technique which I call as a STARS therapy, and which is with a low blood volume, giving on every 4th day in the margins of wound, and then as a monotherapy. So I stopped giving antibiotics, I stopped doing surgeries, I stopped debriding the wounds, and I just gave PRPs. And did I succeed? Let us see. So here is like injury and just PRP. I didn't have to give any antibiotics, no surgical management, just repaired the tendons, left the wound open, no skin grafting, no rotational flaps. A crushed foot with open bone exposed, implant exposed, everything, and I could do it. I could do it the way which nature does it, so that the sole gets regenerated in the way the sole gets regenerated, and the dorsum of the skin is different. So that's a big achievement, because I cannot transplant one sole from other foot to this foot. And then we did it, I became like slightly more adventurous and did on these cases. But unfortunately, I couldn't evolve a way to cover every finger differently, and it came up as a flap to cover the whole of the toes, but the foot remained useful. Now I evolved a way where I can split and do every finger separately. And then I started doing in very severe infections in diabetic wounds. It is again a big problem, because these patients are referred for us for amputation, and we succeeded. And then for bad sores. It's again, in a paraplegic, it's a huge morbidity, and a lot of time it takes the life out of the patient. And then we did a lot of gross microscopic studies, staging of this, how does it heals, and we found that the healing is different. It's a collagenous tissue which gets, if you recreate the skin with the help of PRP, and that's a breakthrough, because I cannot do collagenous any other way. The nature does it is with the fibrosis, and fibrosis, whenever it stretches, it gives a lot of pain. So collagenous does not give you a pain, and it looks very normal, very youngish skin. And then we filed up a IPR, and we got an IPR 3 years later. Unfortunately, why 3 years is, as it happens with all government sectors, many of us have been through those, the copyright office got burnt, and I lost my copyright application. And nobody told us that. When we said, why copyright and patent is not coming, they said, oh, sorry, I lost your copyright. So we need to file again. So my just for all youngsters is, if it is getting delayed, reach the office and find out why it has happened. And then in 2018, we got that copyright. We went through the publications, we published the book also, and got a popularity. And then COVID came, and we were like, no patience, what to do more? So we went back, we will not lose the 2 years, and we went back to animal models and validated on the animals, on the wounds by a control study, everything what we have learned. And we found, yes, we are on the right track. And since 2020, we completed 500 wounds, published it, and 2022 onwards, my last question was still haunting me. Am I witnessing something groundbreaking? So I started using it for gangrene reversals. And I could reverse the gangrene. You can see over here, the bone, etc., everything has reversed. It has come back, the life has come back on it. And then we did it on the diabetic wounds as well. And now, like, I am embarking on controlling the MRSA infection, because PRP has got a lot of antimicrobial properties, and I'm sure, like, this man, I have not given any antibiotics, pouring pus, MRSA positive, young guy, and I could treat him. So are we looking at something which is going to change the way we are thinking the treatments are going on? And my dear friends, yes, we are. The regenerative medicine heals like going to change the whole world within next 5 years. So thank you so much for nice patient hearing. This has been our journey, and if you have any questions, you can reach out to me at drsandeepsrivastav@hotmail.com. Thank you so much for giving me the opportunity.
Thank you, Dr. Srivastava, for excellent presentation. And I think we might take a couple of questions. If we have any questions, please raise your hand from the audience or from the panel. Question? Maybe I'll ask a question that you raised. You go ahead. Yeah.
Before that, I wanted to ask a few questions to our presenter. So the first question to Archana Shrestha, Dr. Archana Shrestha. So what one recommendation you want to give to the Ministry of Health and Population in implementation of PEN package? One recommendation that is so.
Thank you for the question. So if I have to specify one, then I would say that just training is not enough to implement PEN, because Ministry EDCD has been focusing a lot in training health workers from all health facilities. But we can see that the health facility itself is not ready to implement what the health workers have been trained for to do. So we need further interventions to build the capacity at health facility level, to also to invest in their infrastructure, monitoring, evaluation, and recording reporting system, in addition to training.
Okay, thank you so much. And I have one common question to Usha Khimiri and Sulata Karki. So your presentation is very good, your study is very good, and I just wanted to, in a context of Nepal, so cost of spending money to do whatever you are doing, you did, the outcome. So what do you think, what is the cost that needed to implement the way you people did your study in community level? So it's a huge amount of money, I think, right? So do you think it is feasible?
Thank you for the question. And I just would like to say that regarding the digital intervention, as I mentioned before, we use the open source. That is, it comes according to the global good, so it is absolutely free and adaptable to system, and we have some implementation cost and some consultancy cost. And regarding the program, we have a huge program where we have 53 team members, 44 community health workers, and we even did the costing analysis for them, and it was 318 per capita according to our study. So regarding the program, that was the figures, but for the digital intervention, we don't have a particular cost, and we emphasize more on open source system from the concept of the global good, where we have free access, which can be modified, so which can be also scalable in the settings like rural settings, and which can also ensure the sustainability of the program. Thank you.
Thank you so much.
Just one question to Dr. Srivastava. It's very impressive, what you're doing. So the question is, two questions, I should say. One, on average, how long does it take to, for the healing process, and how does it compare to the traditional method?
So like answering first question, so thank you so much. So the healing process, the rate of healing is like 1 mm per day. So like typically we do 2 sessions in a week, because we repeat in 4 days. So a wound which is about 10 centimeters by 10 centimeters should heal by 2 months, 8 sessions. Second is like, that question was, how does it compare to this? So the regenerative medicine PRP-led healing is entirely different from inflammatory healing, which usually we aspire to do because of surgeries and naturally. The major difference is there is pro-inflammatory cytokines which are present in the PRP. So it will lead to collagenous healing, which is better skin, elastic skin, and it has got more tensile strength, and it is less painful compared to fibrotic healing, which is inelastic, and it tends to break through very easily and is painful also on a stretch. So it's a better healing. Thank you so much.
One question, okay. You said the gangrene is also healed by your method. So did you debride before or the gangrene, gangrene is a dead tissue. How come it improves? It's so interesting, right?
So yes, I was debriding it before, but then, as I said, as we gained experience, I stopped debriding. And the way it works is because PRP has got a huge vascular factor, VGFs. And they so intensely the new vascularization will come that it will eat up all the dead tissues, and you will see that it is replaced by a good granulation healthy tissues very soon. Even dead bones. So the black will become a little bit white, and you keep on injecting and have some patients, and gradually you will see it has become red, and then it's like live. So what I would comment is, what you see from your eyes, which is grossly dead, may not be exactly dead.
Okay, thank you. So it's interesting to meet Dr. Sandeep here because I'm PhD student on that topic that he's doing. So I'm doing PRP gel in leprosy foot ulcers. So I want to ask you, so you mentioned that PRP, is that PRP gel you are using or PRP injections?
So I am using PRP infiltrations, and that, say with the experience we have gained, what type of PRP is useful in which wounds. So LPRP, infective wounds, infiltrating around is a wonderful thing. But if you use only pure PRP for infective wounds, it may not help, or help less rather. So those are the experiences which we have, and I will share my details with you, sure. PRF is has a limitation that you cannot make huge PRFs.
All right, thank you all the panelists. In the interest of time, I think we'll close the session now. Thank you, my co-chair.